very big hello to all my dear students. So sorry, still some struggle going on. So I have I have joined little late, but we can start now immediately, right? And how are you all? Prepared, and this time you are fresh to revise with me ophthalmology. It's very, very important for your FMG. Lot of questions are asked from ophthalmology in FMG exam. So let's focus. I would like you all to please try to enjoy the session. Whatever questions you can ask, let's make it very, very interactive. And let's not forget, the purpose of sitting with me is a rapid fire revision, right? What is very important, if you are revising with me and you feel, okay, I don't know this, please don't panic. Just note down the topic. Make it a point that whatever topics we are discussing today, you have studied well before attempting your final exam. Right, guys? Are you all there? Talk to me. Yes? Okay, very good. Chalo. So we start with slide number 1 now. So the basics, and I have tried to be chapter wise this time. What are the things you have to know in optics chapter? Very important, many questions from optics. Everybody knows, if I am looking at this one, yes, Ayush, that is main purpose. I would like to cover as much as possible, humanly possible, okay? But I also expect that you all have studied and you're revising with me, okay? And whatever you don't know, you have to just note down. Let's start. So Snellen's box, one of you have answered me. It's Snellen's acuity chart is the first slide here. Okay, when you talk about the Snellen's acuity chart, I think everybody is very clear about the basics. Should I repeat the basics? 6 by 60, 6 by 36. What is normal? It is the denominator which is normal. A normal person can read this size of the letter at 36. Okay. So this time I have challenges. Just one sec. One sec. Yeah. So it is your 36 meters pe. A normal person can read this size letter, but your patient is reading only at 6 meters. So we should first be very, very clear about this basic. Then and everybody should know that the size of the letter on the Snellen's box, what is the aim? Can I just write the letters on the board and ask you, okay, read, is it a correct way of taking the visual acuity? No, it will be MCQ based session as well. I have combined both the things, so please don't worry at all. Just go with the flow, okay? Then we talk about what is every letter in the Snellen's box, what you have to know. Overall, if I take this letter E, so this is subtending, overall this whole letter is subtending an angle of 5 minutes. And the margins of the letter, like this is the margin of this letter, this is subtending an angle of 1 minute. So let's not forget 5 minutes and 1 minute. Every letter in the Snellen's box, margin subtends an angle of 1 minute. डिग्री से छोटा होता है मिनट, सबको पता है. और ओवरऑल लेटर कितना होगा? 5 मिनट. अगर ऐसा है तो फिर क्या डिफरेंस है? इतना छोटा लेटर, सच अ स्मॉल लेटर, दिस इज ऑल्सो सबटेंडिंग द सेम एंगल. एंड वेयर इज दैट एंगल फॉर्म्ड, गाइज? इट इज at the nodal point of the patient's eye. It is at the nodal point of patient's eye. Right? Okay. So once you know this, all of you, if this is absolutely clear, what is different? Difference is the distance. So be very, very clear about this concept that when you say 6 by 60, this letter is subtending this angle at 60 meter distance. इतना बड़ा letter इतने पास से तो नहीं करेगा ना वही angle जो एक सबसे छोटा 6 by 6 का कर रहा है. अंतर क्या है? डिस्टेंस का. सो इन अ 6 by 6 line, this size letter subtends 5 minutes, 1 minute at 6 meters. Then 9 meters, 12 meters. So it is the distance. So एक 6 by 60 की line वाला जो letter है, that is subtending an angle of 1 minute and 5 minutes at a distance of 60 meters. ठीक है? Okay. So this is important. So once we know this basics, let's move to what is the next slide. Yes, why it is 1 and into 5, this is explained by this slide. 1 minute is the margin. बिकॉज जब भी हम कोई लेटर स्नेलन्स बॉक्स में बनाते हैं उसमें हर लिम्ब के 5 पार्ट्स हो गए, 1 2 3 4 5, ओके, 1 2 3 4 5. So the formation of the letter is such that it is made inside the square with the smaller squares, and that is why the whole letter is always into 5, right? Okay, so if you are clear with this, okay, once this is done and you're clear with this, we come to the next slide. Very important exam question on this one. All of you, can you answer? All of you, come on, answer. That was a very beautiful way to wish. Radhe Radhe. चलो, हरिओम, राधे राधे. चलिए बताइए. So ये क्या है? ये है pinhole, है ना? So all of you, what are the questions asked? We will base our discussion on the questions. First question is, this is a pinhole. What is the size of the pinhole? क्या याद किया है? 1 mm या 1.25 mm. दोनों में से कुछ भी हो सकता है. 1 mm और 1.25, both are the correct measurements for a pinhole. Second question is on pinhole test. We will not forget that आफ्टर डूइंग द रिफ्रैक्शन इन द पेशेंट, आपने पेशेंट को नंबर दे दिया, अब आप टेस्ट करते हो पिन होल से. पिन होल लगाने के बाद 2 चीज़ें हो सकती हैं, या तो विजन जो है वो इम्प्रूव, अगर इम्प्रूव कर जाए, अगर विजन इम्प्रूव कर गई, इफ़ इट इम्प्रूव्स, बताइए इसका मतलब कुछ रिफ्रैक्टिव एरर अभी बचा है. दैट मीन्स द कॉज इज रिफ्रैक्टिव एरर्स. क्यों? क्योंकि वो आपके पेरिफेरल रेज को कट ऑफ कर रहा है पिन होल लगाने से. अब डेप्थ ऑफ विजन और फोकस बहुत अच्छा हो गया. दैट इज़ वाई द विजुअल एक्यूटी इज बेटर. अब आ जाओ, अगर आप दूसरा डिक्रीज हो रहा है, ये भी कॉमन सेंस की बात है. अपने आप सोचो, बीचों बीच कोई भी ओपेसिटी होगी, चाहे वो कॉर्निया में है, चाहे वो लेंस में है, और अब आपने इतने छोटे छेद से देख रहे हो, तो क्या होगा? और कम हो गई विजन, क्योंकि अब दिखाई नहीं दे रहा, राइट? सो डिक्रीजेज इन सेंट्रल ओपेसिटीज. और क्या रीज़न हो सकता है कि आपके जो ये विजन है वो कम हो जाए? अनदर वेरी इंपॉर्टेंट इज योर मैक्यूलर लेजन. ओके, सो मैक्यूलर लेजन में भी विजन जो है वो आपकी कम हो जाएगी, बिकॉज मैक्यूला आप सबको पता है इज रिस्पॉन्सिबल फॉर योर सेंट्रल विजन. ठीक है आमिर, लेट्स फोकस एंड मेक इट स्ट्रॉन्ग. ओके, या राइट, I'll be speaking in both languages. If by chance I speak in Hindi, I immediately translate it into English, so please don't worry so much, right? And if you really don't understand English, that will never happen. Anyway, so this is about your decrease will be central opacity and macular lesion. So these are the 2 points which are very, very important regarding pinhole test that will be asked in your exam. We come to the question now. You all were saying MCQ base. So here we have the question. A patient with a corneal scar has a visual acuity of 6 by 36, which improves to 6 by 18 with a pinhole. The most likely reason. So this is a PYQ of FMGE exam. So what can be the reason that the vision is improving? Any corneal scar is making the cornea irregular. Because it is making the cornea irregular, yes, therefore there will be irregular astigmatism. And if there is an irregular astigmatism, how do you correct it? We are going to this will definitely be improved if I'm using a pinhole, isn't it? So that is why we have learned any improvement with pinhole. क्या पढ़ा हमने? It is causes refractive error. Right guys, we next talk about this one. All of you answer me. What is this? Where the patient is being examined very close to the eye like this. कौन सा instrument है? What is this instrument all about? This is your so it will be okay, MBBS 8981 cylindrical lens. Yes, we treat astigmatism with cylindrical lenses, but if there is irregularity of the surface of the cornea, even that can become very challenging, and we have to mainly look into that as well. Okay, it's an irregular astigmatism, isn't it? So maybe for example, where have you learnt irregular? चलो पहले इसको और क्लियर कर लो. irregular astigmatism को आपने कहाँ पे मेनली पढ़ा हुआ है? This will lead to irregular astigmatism. Keratoconus, है ना? क्या ट्रीटमेंट है keratoconus का? Hardly specs can help. Okay, so it is mainly either we go for semi-soft or rigid gas permeable lenses, right? Or we have to do some surgical procedure to replace this irregularity with the regular surface, that is keratoplasty. Is that okay? Right? Okay. So that is why we can't only answer cylindrical lens. If we are talking about irregular astigmatism, the challenge is absolutely different. Where have we learned it? Don't forget, we have learned this in keratoconus. And we already remember the treatment of keratoconus. Okay. We come to, this is direct ophthalmoscope. Very good. What are the points you have to learn and can be asked in a direct ophthalmoscope, guys? Let's understand. सबसे पहले सबको पता है, बताओ. सब लोग आंसर करो. मैग्निफिकेशन कितना होता है? All of you, what is the magnification in a direct? 15 times. What is the field? एक बार में कितना एरिया दिखाई देगा? At one time, how much of the area is visible? It is 2 disc diameter. What is 1 disc diameter? 1.5. So we are saying 2 into 1.5 mm. Very nice. All of you keep answering. Okay? So this is another important thing. Then they will ask you what is the type of image formed in direct. It is always virtual and erect. And if the field is less, अगर कम field है देखने पे, एक बार में जो देख रहे हैं वो एरिया कम दिखाई दे रहा है, तो mainly where are you going to use this? We are mainly using this instrument to see the central retina. Is there any other question? Yes, the question has also been asked regarding your that which eye of the patient and which eye of the examiner. This is in front of you. It is always the same eye. The examiner has to use his right eye if he has to see the right eye of the patient. Okay, so same eye. And what do you instruct to the patient? Don't say look in the light. If you say look in the light, there will be pupillary constriction and you can't see behind. You always say it is that you ask the patient to look straight. Okay, कि तुम सीधे सामने देखो. Right? So these things have been asked in the exams. So we will remember all these points. This is important question. Today we are only talking about questions. Right, guys. So once you know this, we come to this one. But before I come to the second slide, can you all let me know one important thing? What is distant direct ophthalmoscopy used for? At what distance do we do? Chalo, answer karo. Next question tha mera, distant direct ophthalmoscopy. So distant direct ophthalmoscopy. बताओ. So distant direct ophthalmoscopy को आप कहाँ पे जो है generally use करते हो? Yes, 25 centimeters is the distance at which we do. This is exam question. Very nice. And what are we trying to see? मतलब समझ में आ रहा है? जो instrument को बहुत पास से जल जाके देखोगे, अब उसी को थोड़ा सा distance से देख रहे हो. You are watching it, so you are examining at a distance. So when you do that, you're mainly looking at the media of the eye. Very nice. We come to the next slide. Tell me about the next slide. What should we learn in the next slide? Chalo, batao. Talking about the... So in the next slide is indirect. Very good. Now what are the points you have to remember in the indirect? Can you see the examiner is holding a lens? First question is, what is the strength of this lens? This is number one question. It is plus 20 diopters most commonly. And but let me tell you, it can range from plus 13 to plus 30. But yes, here it is plus 20. Second important point, it is where is the image formed? Image is formed between the lens and the examiner. Okay? Matlab yahan pe. See, I'm writing eye here. This is the place where image is formed. It's in the air. जब मैं lens hold कर रही हूँ, ये light source है. So the image is formed in the air. It's an aerial image in the air. ये हो गया question number 2. Next question is, of course, this you know, what is the magnification? It is either 3 times or 5 times. What is the field? This time it is 8 disc diameter. And therefore, what do you see in indirect? We are seeing, very good, already answered. So many of you have answered. Yes, Shania. Yes, Priya. Very nice. It's real and inverted. Right? So it's a real and inverted images form. And what are we trying to see through indirect ophthalmoscopy? You will say it is the periphery. Hai na? So peripheral area or periphery of the retina. Peripheral retina. So if you remember these points, you are going to answer any question on these two instruments. This is what they ask you in the exam. Nice. We come to the next one. Now again, as some of you want MCQs, I've included both. Answer this question. This is your exam question. Which of the following is not true about the procedure done using the instrument shown below? So we have to answer which is not true What is this? This is a direct ophthalmoscope. अभी अभी हमने सब पढ़ लिया है. So all of you, condensing lens is not required. No, not required. So this is a true statement. It is used very close to the patient's eye. Yes, it's a true statement. Real inverted, we know this is not true. This is a false statement. So this will be the answer. Magnification is 15 times. Very nice. We all know it's virtual and erect. Come to the next question. A worried mother brought her son for the vision examination when she noticed him reading a book too closely. जब छोटे बच्चे, if they are reading something like this, or when they are watching television, they are squeezing their eyes. What is this? It is myopia. Why do they squeeze their eyes? Anybody? My question is, why will a child narrow his eyes while watching a television? All of you answer me this question. Why? Why does he narrow his eyes while watching the television is my question. Tell me. Nope, it's not about accommodation. So when he's squeezing his eyes to what? Because he's looking at the far, he may not be looking very close. Accommodation will come into picture when we talk about the near vision. So he's watching a television, he's squeezing. Any squeezing causes pinhole effect. Okay? And actually this will help his vision because it is cutting the peripheral rays. So that is the reason he's squeezing. So he is a case of myopia, and therefore what will you answer? Of course you know is a concave lens. So all of you, I think you are very, very clear about the refractive errors. A quick way of recap according to my style. What is myopia? M for M, myopia matlab more than required. So it means that power is more. M for M, power is more. So if the power is more and the eye is longer, large axial length, what is happening? Light rays will be focusing even before reaching the retina. And because I need the focusing here, I want to decrease the power by using concave lens. How much I had to decrease is a measure of myopia, hence we note it down as minus. That is why myopia is indicated as minus. Why? Because that is the measure of how much I can decrease. Okay? That is the measure of myopia. Come to hypermetropia, quick revision. This time it is power is less than what I require. If the power is less, so what will happen? What will happen? Eye is small in hypermetrop and therefore light rays are focused behind the retina. We need the focusing somewhere here. Therefore, to increase, I use convex lens. How much I have to increase to focus on the retina is a measure of my hypermetropia. We answer it is as plus. Aisha, it's even I have no idea what exact time I should say it will end. You all have just said you want me to give you our maximum whole revision, cover everything. So even I'm wondering when it will end. I'm trying my best that it ends within your alertness time, that you can enjoy also. It should be productive. So let's hope for the best, right? Okay. Okay, so this was about your hypermetropia. This is, and the lens is convex lens. And everybody, let's revise astigmatism. What is astigmatism? कैसे पढ़ाया मैंने? If this is the cornea, one curvature is more curved than another. So more the curvature, more the refractive power. So this is more, this is less. So difference of refractive power between the two eyes is axis. Difference of refractive power between the two axes. So whenever there is a difference between two axes, this is what is called astigmatism. Isn't it? We'll talk about more about astigmatism. We come to the next slide and here it is. What is the classification of astigmatism? There are many ways. One way of classifying is this one. What is this? If you see one axis se jo focusing hai, that is in front of the retina and one is on the retina. So if it is on the retina, it is emetropic. So how do you depict a simple myopic? Simple myopic means if one axis has no number, one axis is a minus. This is simple myopic. You can note it down. What is simple hypermetropic? Any axis, suppose this time this has a hypermetropia with no number. This is simple hypermetropic, this one. Compound means both, in this case what it is? Myopic. Both are in front of the retina. Can you see that? Both the focusing is in front, so it's a compound myopic means this. And compound hypermetropic का मतलब दोनों plus है, and if one is plus, one is minus, it is called mixed astigmatism. Right? थैंक यू फिट मेडिकोस. ओके, आगे पढ़ते हैं. डन? समझ आ गया? ये इजी था. ओके, वेरी नाइस. सो वंस यू नो दिस, व्हाट इज द अदर वे ऑफ क्लासिफाइंग एस्टिग्मेटिज्म? Another way of classifying astigmatism, I hope you all are focusing, guys. Another way is with the rule and against the rule. These are the two important and on which the questions are asked. One is with the rule. With the rule matlab, due to the lid pressure, we expect some more curvature of the vertical than horizontal. If that follows, if vertical is more than horizontal, we are calling it with the rule. क्योंकि lid के pressure से भी naturally भी कुछ difference ऐसा है कि vertical हल्का सा ज़्यादा है, ना के बराबर. This isn't normal. But now if the vertical is more, then this is your than horizontal. That is the reason we are saying it is following the rule. It is with the rule astigmatism. But if it is vice versa मतलब अब क्या हो रहा है? This time it is the horizontal is more than vertical. Now if horizontal is more than vertical, this is against the rule astigmatism. Is that clear to you all? ठीक है? Okay. If this is clear to you all, generally the numericals are not asked in an FMGE exam like this, but I would still like to take it because it will clear your concept. Only two things, okay? Two things. Pehli cheez, I am asking you, what is this? Is it, all of you answer this question, is it with the rule or against the rule? All of you, quickly. You can go through as many sessions as you want to thorough and reinforce your preparation. Focus on sitting in front of me and answering questions and learning here. How are you getting time to ask anything else? We are studying here seriously, right? Come on, which type of astigmatism is this? हम लोग थोड़े दिन last में 2 minutes बातें भी करेंगे, okay? Then you can ask all these questions. अभी focus करो, revise करो. So -3, -1, all of you. Yeah. -3. Now where do you make a mistake? Are you all alert? And yes, -3, minus myopia. M for M, more than required. So when you say -3, if in emetropia, what is the total refractive power of an emetropic eye? It is 60 diopters. -3 का मतलब होता है इसमें 60 के अलावा 3 और हैं. It is 63 diopters. -1 का मतलब it is 61 diopters. Yes, this is with the rule. Okay? Now I ask you another one. Here is it. This time this is +3 and +1. I have just reversed the sign. So it's a hypermetropia. Less than required. यहाँ पे +3 का मतलब क्या हुआ? It means that it is 60 - 3, 57 है. And this one is 59 diopters. So now this is against the rule. Okay? So be clear about this. This is enough. Right? Okay? Chalo. So once you know about what is myopia, hypermetropia, astigmatism, we have revised this, how to classify, what questions are asked in astigmatism. अच्छा, ओके, प्लस माइनस क्या नहीं समझ में आया? अभी पढ़ाया था ना कि myopia is indicated as minus and hypermetropia is indicated as plus. ठीक है? तो अगर मैं बोलूँ मेरे आँख में, उदाहरण के तौर पे मैं बोलूँ मेरे आँख में पावर है -2, तो व्हाट डज इट मीन? टोटल रिफ्रैक्टिव पावर इज मोर देन रिक्वायर्ड. माइनस हेयर वी डोंट सब्सट्रैक्ट हेयर, उल्टा होगा ना, बिकॉज इट्स अ मायोप. एक्चुअल पावर हेयर विल बी 60 + 2. Isn't it? This is what I am explaining. Javeer, are you here? Did you now get it? So when you say I have a hypermetropia of +2, it means this much is less power. So hypermetropia is less power. Emetropia का number तो पता है ना, 60, 58 to 60 diopters is a total refractive power of a normal eye. तो अब आप यहाँ पे क्या करोगे, अगर ये +2 आपका नंबर है आँख में, तो एक्चुअल रिफ्रैक्टिव पावर आपकी माइनस ये हो गया. नाउ इज इट ओके? No, let's always fit medicos. Let's always, there is no, if your concepts are very clear, you don't need any trick at all. Just have clear concept. I think this is very, very clearly explained now what I'm explaining. Is there any confusion? No, na? Chalo. Awesome. Very nice. So this is asked in the exam. We have to be clear about this. अब इसके बाद क्या पूछा गया है वो है ये. Again back to the MCQ. You are studying the optics of a patient with a regular astigmatism. Identify the point at which the clearest image is formed. Tell me. What do you mean by, so where the clearest image is formed? All of you look at this one. Okay, एक बार इसका concept समझ लो. Sturm's conoid. You're looking at Sturm's conoid. What is that? This is an astigmatic lens. Okay, I'm quickly explaining. V vertical में इसमें दिखाता है example में that the power of the vertical axis is more than horizontal, and this is the reason the vertical is focusing much before. So when the vertical is focusing, it is at point B, you get a horizontal line. Now abhi horizontal is focusing here, that is at the F, because the power is less in horizontal. It's a flatter axis. Vertical here is a steeper axis. So actually this is what with the rule astigmatism in this example. Anyways, what you have to understand, what are these A, B, C, D, line ban gayi, oval ban gaya, circle ban gaya, vertical oval ban gaya. Just understand when the light rays are actually undergoing these changes. आपने suppose इसके आगे एक कार्डबोर्ड लगा दिया, तो क्या शेप लाइट की बन रही है? This is what is Sturm's conoid, or Sturm, whatever you want to pronounce. I pronounce it as Sturm's, कुछ लोग Sturms बोलते हैं, whatever it is. ठीक है. सो स्टर्म्स कोनॉइड में आपने ये जो आपकी हॉरिजॉन्टल एंड वर्टिकल, ये क्या आपके कार्डबोर्ड पे कैसा शेप आ रहा है? दिस इज व्हाट इज रिटन हियर. गॉट इट? दैट इज A B C D E. नाउ व्हाट हैपेंस? यू ऑल आर आंसरिंग, व्हाट डिड यू आंसर? D. Some are answering something else also. So actually D is a point of circle of least diffusion. And what is circle of least diffusion? ध्यान से सुनो. जब एक बार वर्टिकल एक्सिस फोकस कर गया, डू यू रियलाइज आफ्टर फोकसिंग फ्रॉम द वर्टिकल इट विल नाउ डाइवर्ज, बट हॉरिजॉन्टल इज स्टिल फोकसिंग. सो द अमाउंट ऑफ कन्वर्जेंस ऑफ हॉरिजॉन्टल व्हेन इट बिकम्स equal to divergence of vertical, this is the circle of least diffusion, and therefore you get the clearest image here. I hope you have understood. So we answer D. Achha, you all are saying option B. Yeah. So we answer D. Got it? What did I say? एक बार focus होने के बाद vertical will diverge. The amount of divergence of the vertical is equal to the amount of convergence of the horizontal. I hope now you understand. Yeah. Happy to know that. V, Y, B, H, V, V. This is how I will call you. Make it simpler. Okay, we now come to look at this one. What is this slide? We all understand color vision, right? So, very important screening test. This is asked in the exam. It is Ishihara chart. Everybody should know this, that Ishihara chart is mainly to screen red, green blindness. These are the 2 points. Everybody knows if you can see the number, you are not color blind, but you can't read the number inside on these plates, then you may be color blind. Right? And then what is this one? This is a better and more accurate. This is called Farnsworth, sorry. $100 hue. But there are no 100 caps. These are only 85 caps. But we call it 100 hue test. मतलब एक कलर के अलग अलग shades हैं. Darker, 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 or lighter, lighter. Okay? So this is more accurate. This is the 100 hue. Just know this. We come to the next question. A 6-year-old child is presenting with a refractive error of -2. So there are a lot of questions in optics, and that's why I'm covering like this. So presents with refractive error of -2 in the right and -5 in the left. Fundus examination normal hai, visual acuity. Fundus examination reveals normal and visual acuity and retinal findings. सब कुछ normal है. What is the most likely diagnosis? All of you, any difference of refractive power, any difference of refractive power between the two eye of more than 2.5 diopters, isn't it? So this is what is your, when it is more than 2.5 diopters, this is your anisometropia. Yes. Yes. So we will be answering here. It is anisometropia. So now you know another error, that is anisometropia. Are we left with any other refractive error? Myopia, hypermetropia, astigmatism. Then anisometropia. One more is aniconia. What is aniconia, all of you? This also you should know. It is difference of image size between the two eyes. Right? So, difference, yes, it may lead to dark medico. It may lead to amblyopia. And what is amblyopia? When you're not getting any pathology, but still you are not able to improve the vision to 6/6. Here the vision is improved to, is normal. Acuity is normal. Right? So this one is aniconia. Kya hota hai? This is your next refractive error where there is difference of image size between two eyes is should be more than 5. 5% is normal. I hope you all know that physiologically we both have a difference of 5% in both eyes, and this 5% of aniconia is helping us in depth perception. Take. Okay. Done? Anything more than that? What will be the problem? If the image size of the two retinas are different, इसमें कोई और size का image बन रहा है इसमें ये. So, it cannot fuse by the brain. So, whenever the two images are not being fused by the brain, we will be seeing two. So, any aniconia can actually lead to diplopia. Okay? समझ आ गया? चलो, very good. Rahul, what is? अच्छा सूर्य, फर्स्ट आई विल रिपीट दिस. आई एम सेइंग दैट नॉर्मली हम लोग के आंख में दोनों रेटिना पे इमेज बन रही ना. यू आर लुकिंग एट मी, सो माई इमेज इज फॉर्म्ड ऑन योर राइट रेटिना ऑल्सो, लेफ्ट रेटिना ऑल्सो, बट यू आर नॉट सीइंग मी एज टू, यू आर सीइंग मी एज वन, because both your retinal images are fused by your brain. Now, what is important to understand that we have a very mild 5% of difference in the retinal images, which is physiological, and it helps us in depth perception. This much brain is actually adjusted and it fuses the two images. But when the difference is more than that, the fusion by the brain becomes difficult. So, if the two images are very different in size, they cannot be fused. They will be seen as two different. If the images are not fused, तब आप मुझे दो देखोगे, है ना? So that is what I mean. Is it now clear? ठीक है, Surya? Okay. Then we talk about अच्छा. Okay, Preeti. Now you let me know another important question. I think somebody had asked me. I could not understand the question, Prem, which you are asking about retinoblastoma here. Amblyopia, one of you were saying, मैम मुझे amblyopia समझा दो. अभी आगे क्वेश्चन आएगा, उसको समझाएंगे. ओके, ये कौन सा क्वेश्चन है? अ 5-year-old फीमेल पेशेंट इज प्रेजेंटिंग फॉर हर फर्स्ट कंप्लीट आई एग्जामिनेशन आफ्टर स्कूल विजन स्क्रीनिंग फाउंड unequal visual acuity. Her parents have not noted any eye problem, but visual acuity right eye में तो 20/20 fit में दिया हुआ है, left eye में 20/80 है. Right? So the rest of the examination, including fundus, is unremarkable. अब ये क्या है? आप समझ लो. One of you were asking about what is amblyopia. So I have a patient. मैंने उसको एग्जामिन किया, सब कुछ ठीक है, चश्मे में कोई भी शीशा लगा रहे हैं, कुछ भी रिफ्रैक्शन कर रहे हैं, नीचे तक पढ़ ही नहीं पा रहा मरीज एक आंख से. फिर मैंने आंख को देखा, एंटीरियर सेगमेंट भी ठीक है, पोस्टीरियर सेगमेंट भी ठीक है, एबनॉर्मैलिटी तो कोई लगी नहीं रही. अच्छा, देन दिस इज अ केस ऑफ amblyopia. So we all know, please, if you haven't learned this topic, it's very important, please learn it. It is partial loss of vision. It's a loss of vision which is not being corrected by your glasses with no organic cause, right? ठीक है? Yeah. See what will happen? That is called lazy eye. Now you have to force that eye to work. So this is another exam question in your amblyopia, that what is the treatment of choice? Treatment of choice is occlusion. But बताओ इस बच्चे में कौन सी eye amblyopic है? All of you answer this. बताओ बताओ. Yes, Amrutha, that is important. You should know this. This much which I have taught you is enough. इससे ज़्यादा नहीं पूछता FMG में. Cover the good eye. Okay, and force the amblyopic eye. So which eye is amblyopic in this? It is the right eye. Very good. So this is the amblyopic eye, and we will not forget that it is mainly the occlusion of normal eye. That is mean treatment is occlusion of normal eye. Chalo. Got it now? Very good. We come to the next. This is how the question has been placed to you all. The muscle inserted nearest to the limbus. Answer is already there. The muscle inserted nearest to the limbus was one of your FMG questions. So we should know what is this. So the muscle insertions at the limbus, if you talk about the recti muscles, originate कहाँ से होती है? Annulus of Zen. और apex of orbit से annulus of Zen से originate होके eyeball पे वो anterior to equator insert होती है. You have to know this, that medial rectus is 5.5 mm away, inferior is 6.5, lateral 6.9 and superior 7.7. Right? 5.5, 6.5, 6.9, 7.7. Just learn it. And if I am joining all these dots, this spiral which is formed is what is called spiral of Trulix. ठीक है? Spiral of Trulix. Yes. Right? So you should know this very well. Okay. So once you know this, I think this blank slide was, I must have something in my mind. है ना? Yes. Okay. MBBS 8981 MILS हमने आपको पढ़ाया हुआ है वहाँ पे sequence of breaking of the orbit and decompression surgery, the walls for which are broken. First medial, and maybe you are talking about this? I don't know what you are trying to say. Anyway. Okay, numericals related to glass prescription. I don't think they have been asked in exam as such. If you are requesting, definitely I will discuss. Okay, so first of all, when you're talking about this muscle, I would like to also understand that do you all remember the action of muscle? Action of muscles, we all know there are, very quickly revise with me, how many muscles are there? 6 muscle है, 6 movement है, 4 recti, 2 oblique, correct? So 4 recti, 2 oblique. Now for us to learn the action, मैं कैसे बताती हूँ? Have I included that? Wait a minute, let me check. Okay, now. Okay, so how do I teach this? That we divide it into horizontal and vertical. So when you say horizontal and vertical, how do we learn horizontal? We use very, very easy. Lateral rectus causes abduction. Abduction is away from the nose, and medial rectus causes adduction towards the nose. We come to the vertical. Vertical we learn with 2 mnemonics, that is and rad. Is says that superiors are in tortoise. And what does rad say? Rad says that recti are adductors. So if we know this, we can learn everything nicely. Isn't it? So vertical muscles, please learn like this. Okay? Yeah. Right. So all of you, if I talk about the vertical muscles, it is superior rectus, inferior rectus, superior oblique, inferior oblique. यही है ना 4 muscles. Think with me, primary action, secondary, tertiary. Because the main action of adduction, abduction किसका होता है? Horizontal muscles का. इसलिए vertical में ये सारे actions tertiary होते हैं. Recti क्या है? Adductors. So I will write here adduction, adduction. और यहाँ पे क्या लिखोगे, एबडक्शन एबडक्शन। ये रो कंप्लीट हो गई। अब आ जाओ वन बाय वन। सुपीरियर रेक्टस, ऑल ऑफ यू रिमेंबर सुपीरियर रेक्टस प्राइमरी एक्शन एलिवेशन, and superiors are in tortoise, so I write here in torsion. LR6SO4 is telling you the nerve supply of each muscle, not the action. Then we talk about the inferior rectus, depression and extorsion. Easy. So if you know one row is complete, everything becomes easy. In oblique, the primary action is always torsional. So what is the action of superior oblique? In torsion. Superiors are in tortoise. For inferior oblique, it is extorsion. This is the primary action. अब यहाँ पे ध्यान रखना है, इट इज ऑब्लिक उल्टा काम करेगा, सुपीरियर है डिप्रेस करेगा, इंफीरियर एलिवेट करेगा. सो सुपीरियर ऑब्लिक विल कॉज डिप्रेशन, ये डिप्रेस करेगा, इंफीरियर ऑब्लिक एलिवेशन एलिवेट करेगा. समझ आ गया? ओके, सो दिस इज हाउ यू शुड लर्न योर एक्शन ऑफ मसल्स. क्वेश्चंस आ सकते हैं. Thank you for this wonderful compliment. Thank you, Godara. Okay, so once you know this, हाँ चलो फिट मेडिकोज. अब हम पढ़ते हैं व्हाट आर योक मसल्स. योक मसल मतलब दो आँख की वो दो मसल्स जो एक साथ काम करें, isn't it? So जब आप बात करते हो इसको क्या बुलाते हो? कॉन्ट्रालैटरल सिनर्जिस्ट. योक मसल्स आर कॉन्ट्रालैटरल सिनर्जिस्ट, इन्हीं को बुलाते हो योक मसल्स. अगर आपसे ऐसे पूछ लिया कि what is the yoke muscle of right inferior rectus? So all of you, any vertical muscle पे yoke muscle पूछता है, life easy है. I've taught you right का left कर दो, inferior का superior कर दो, recti का oblique कर दो. So the answer is it is left superior oblique. Just turn every letter opposite. And I hope you understand this. When you say right, I have explained you the concept earlier also. Right side पे अगर हम लोग इसको ऐसे पहले समझो, फिर हम लोग देखेंगे ये डायग्राम. अगर मैं ऊपर अप अगर मैं चलो, इफ आई एम लुकिंग स्ट्रेट राइट, इट्स इजियर. राइट लैटरल, लेफ्ट मीडियल. इफ आई एम लुकिंग टू द लेफ्ट, लेफ्ट लैटरल, राइट मीडियल. ये तो क्लियर है. अच्छा, अब हम लोग पढ़ रहे हैं दैट वी आर लुकिंग राइट एंड अप, डेक्स्ट्रो एलिवेशन, इजंट इट? सो अगेन आई एम मेकिंग थिंग्स इजी फॉर यू. डेक्स्ट्रो मतलब राइट, एलिवेशन. आपको इसको कैसे सॉल्व करना है? सपोज आई आस्क यू अ क्वेश्चन हियर, व्हाट आर द मसल्स एक्टिंग इन डेक्स्ट्रो एलिवेशन? सो व्हेन यू से मसल्स एक्टिंग इन डेक्स्ट्रो एलिवेशन, ऑल ऑफ यू गाइस फर्स्ट टेल मी व्हाट आर द मसल्स व्हिच आर एलिवेटिंग योर आई. सो व्हाट आर द मसल्स व्हिच आर एलिवेटिंग योर आई? बोलो क्विकली ऑल ऑफ यू, व्हाट आर द मसल्स व्हिच एलिवेट योर आई? जल्दी बताओ. 3, 2, 1. Superior rectus, inferior oblique. Chalo, agreed. Now I hope everybody knows this concept. That's why I'm repeating it here. In an outward deviated eye, जब आँख बाहर की तरफ जो आँख है उसमें कौन सी मसल एक्ट करेगी as elevator and depressor? Recti. So if you remember this, you will never make a mistake that in an outward deviated eye, it is the action of elevation and depression. किसका होता है? Recti का. तो अगर हमने डेक्स्ट्रो एलिवेशन की बात की, कौन सी आंख आउटवर्ड है? राइट. कौन सी इनवर्ड है? लेफ्ट. लेफ्ट नाक की तरफ है, यानी इसका रेक्टाई काम करेगा, इसका ऑब्लिक काम करेगा. दैट्स वाई रेक्टाई वेल के आगे लगाओगे राइट सुपीरियर रेक्टस, लेफ्ट इंफीरियर ऑब्लिक. ठीक है? सो दिस इज द वे यू आर गोइंग टू थिंक एंड सॉल्व. Yes, Dark Medico, I will not go into detail into that. We have limited time. Right. Then we talk about, this is what is given here. If this is the right gaze, we have just discussed what is left gaze, what are the muscles. Then we just discussed, this is what is dextro elevation. है ना? Outward eye में right superior rectus, left inferior oblique. Isn't it? And if I am looking on the left side, this becomes left. So this is your levo elevation. This will be levo elevation. And similarly, this is dextro depression, and this one is your levo depression. Okay? Chalo, next paro. Why all these things are important? Very recent, this FMGE, this was also asked, and you should know some assessment of the deviation of the eye, what tests are done. So, kya question aaya tha? The falling light reflex was seen in the patient. How much is the deviation? तो अगर आपसे ऐसा सवाल आ रहा है जिसमें इस तरह का ये आपका क्लिनिकल स्लाइड दिया है, आपको भी पता है राइट आई डेविएटेड है, इट इज डाइवर्जेंट और कन्वर्जेंट, डाइवर्जेंट, इट्स एन एक्सोट्रोपिया ऑफ द राइट आई. हाउ मच, what is that test called? Hirschberg test. Hirschberg test, what does it say? Hirschberg's test says something this. What you have to know? It's a rough assessment of amount of deviation. Normally your reflex should be here. If it is on the inner border of your pupil, it is around 18 degree. Outer border of pupil squint is around 20 degree. Between the pupillary border and the limbus, it is around 35 degree. And if it is at the limbus, this is one of the constant degrees. अलग अलग बुक में कई बार 18 और 20 के बदले कुछ और भी दिया होता है, लेकिन 45 is always fixed in every source. That is when it is at the limbus. Now, once you know this, you go back to the question and you see here also it is at the limbus. The reflex is seen at the limbus. It's a 45 degree exotropia. How do you convert it into prism diopter? Double. So 90 prism diopter exotropia will be the answer. Okay? Yeah. So this is another important thing, how you will solve. Yeah. Then we talk about is what is this? Now that was a rough assessment ना, कि हाँ अंदाज़ा लग रहा है कि यहाँ पे रिफ्लेक्स है तो इतने डिग्री होगा. But if I want to really be very very accurate, if I am treating and I have to do the surgery, I should know the exact degree of squint. Then I do this test. What is this test? Prism cover test. You're putting a prism. See, there are different strength of the prism. This is a prism bar. ये अलग अलग strengths हैं. Okay. So you're just shifting this. At what prism strength there is no movement in the uncovered eye? That is what is prism cover test. ठीक है? If you want to note down, at what prism strength there is no movement of the uncovered eye. This is what is prism cover test. At what prism strength, prism diopter, there is no movement of uncovered eye. Is that okay? Chalo, next पढ़ो. Which of the following statement is wrong for the above figure? सबसे पहले इस पे दिख क्या रहा है आपको? It's a right esotropia. And which nerve palsy it will be? Convergent squint, lateral rectus is gone, so it's a LR palsy. So it's a right esotropia due to 6 nerve palsy. Yes, that is correct. It causes horizontal diplopia. Horizontal muscle is gone, so yes, it will cause horizontal diplopia. मतलब both the false and true image are aligned horizontally. It causes a crossed diplopia. I think I have taught you all this, that crossed and uncrossed का बहुत सिंपल सा तरीका है याद करने का. एक में क्रॉस बनाओ और एक में बिना क्रॉस के लाइन खींचो. अब वन बाय वन सुनो. In the one which you made a cross, make an arrow at the head. Don't forget, cross diplopia always occur in exotropia, divergent. Okay, so that means in exotropia you get crossed diplopia. मतलब क्या होता है इसका? Cross diplopia. If this is the squinted eye, the false image is opposites on the opposite side than the true image. So this is crossed diplopia. And how to remember uncrossed is this. See, there is no convergence. So in esotropia, there is uncrossed diplopia. Okay. Esotropia means LR palsy and exotropia means MR palsy. Right, guys? So now this will be the answer because this is a wrong statement. And does it lead to face turns towards the right side? Yes, because it will always lead to face turn towards the squinted side. So this is also correct. Right? Okay. So this is the way you will learn किस squint में कौन सा diplopia होता है. Are you all clear with what I just said about crossed and uncrossed? I am repeating it. Suppose these are the two images and this pen is the false image. Suppose this one is the false image. So, and this is the squinted side. If this false image is towards the squinted side, it is uncrossed. But when this false image is opposite to the squinted side, it is crossed. Right? Yeah. Okay, we come to the next question. So that was your lateral rectus palsy. I hope you revised with me all the features in a lateral rectus palsy, which is, that means 6 nerve palsy. You will get a esotropia with face turned towards the side of the lesion, because towards the affected side. Diplopia is always maximum in the action of direction of paralyzed muscle. Don't forget that. What else you have learned? It leads to uncrossed diplopia. Okay, अब हम नेक्स्ट पढ़ते हैं. ये किस पैल्सी, ये कौन सी पैल्सी है? So if you will see here, what I can see in this, there is ptosis. What I can see here, eye position is down and out. Yes, we are talking about left eye third nerve palsy. Okay, and if you are going to see, when this patient is looking to this side, no adduction, right? But on the other side, this is normal abduction. Yes. So we know we are talking about third nerve palsy. Great. So we have a question here. 60-year-old man was brought to OPD by his daughter with the complaints of drooping of his left eyelid and double vision. So here this was the drooping, right? And he was having double vision. When we open the eye, we see the position something like this. The pupils are dilated, which is obvious in case of third nerve palsy. So we know we are talking about oculomotor now, right? So keep this in mind. Yes. Now we talk about this one. Can you tell me what this slide is showing you? So if I see the without glasses, this child has a, if this is her right eye, na, this is the left. So left eye ESO, isn't it? So the child is presenting with left esotropia, but this looks accommodative. Why? Because when she is wearing the specs, this is straight. All of you, what type of refractive error is corrected in the specs is my exact question to you all. All of you, what type? Which refractive error has been corrected by the specs in this child? Answer me. Very good. Yes, Vivek, it is hypermetropia, isn't it? Because this child was hypermetropic, too much of hypermetropia, the eye compensates by exerting so much of accommodation that eye will converge. क्यों? क्योंकि convergence, meiosis, accommodation all go hand in hand. So now you have put a specs here. What happens? The eyes become, you have relaxed the accommodation, relaxed the convergence, and therefore the eyes become straight. So this is what type of squint? This is a refractive accommodative esotropia. I hope you agree. It is this. Yeah. Okay, we have a question here. Which of the following is the best line of treatment in a 3-year-old child presenting with a recent onset of 15-degree accommodative esotropia? So we all know best line of treatment for 15-degree accommodative esotropia. First is always refractive correction to check for if there is any hypermetropia or not. You agree with that? Yeah. Yes. Most common ocular manifestation of COVID-19. Okay, before I come to this topic, all of you, one of you had requested for spectacle prescription. What type of question do you want? Because now we will be moving to the next topic here. So with this prescription, see, in details of this is not totally asked, but okay, very quickly, if I come back to your astigmatism वाला क्वेश्चन, आपको ये क्वेश्चन ऐसे भी दिया जा सकता है, -3 diopter spherical, so I'm writing anything, okay, and -1 diopter cylinder at 90 degree. Okay, so this is the patient's spectacle prescription. Now I ask you, okay, tell me what is the type of astigmatism in this patient. Always convert it back into the retinoscopic reading first. How do you convert? You make 2 lines here. -3 diopter spherical का मतलब हुआ -3 इधर भी है, -3 इधर भी है. -1 diopter cylinder at 90. Everybody should know that axis, जिस पे भी एक्सेस होगा पावर उसके 90 डिग्री पे होता है. इफ आई एम राइट, क्यों? क्योंकि सिलेंड्रिकल लेंस की बनावट ही ऐसी है, ये भी कॉन्सेप्ट जरा अच्छे से समझ लो। एक सिलेंड्रिकल लेंस की बनावट, सिलेंड्रिकल lenses are made like this that the power and the axis are perpendicular to each other. Sorry. The power and the axis are perpendicular. So if I put the axis at 90 degree, I am giving the power at, sorry, if I am putting the axis, if my axis is at 90, my power is at 180. If my axis is at 180, my power will be at 90. Do you get me? So it's always the opposite. The moment I write at 90 degree, -1 cylinder should actually go into 180. So I will write -1 here. So my actual retinoscopic reading is what? -3 and -4. Is this clear now, all of you? And therefore, what type of, once you have converted, now you should comment on type of astigmatism. So what have you converted into? Converted this into retinoscopic reading. It comes as -3 and -4. Therefore, what type of astigmatism? All of you will answer me. Yes, very good. Dark medico, you just turn your name into light medico. It's always good to talk about light, brightness, hope, happiness. Isn't it? Okay. So, we talk about this. Bolo, kya hoga? It is very good. Against the rule. क्यों? क्योंकि जब हम बोलते हैं -3, what is the power here? -3 का मतलब, what is the power in a -3 myopia, all of you? No. Why after I have FMG exam? No. Live this moment. This moment is equally very important in your life. Okay? Don't postpone your things. Don't give conditions to yourself to be happy. Every moment of your life is equally precious. You will not get this moment back. ये सब एग्जाम चलता रहेगा. Okay? If you are determined to do your best, if you can discipline yourself, if you're determined to be always better than yesterday, if you're running your own race, if you're very, very sincere towards yourself, nobody will be able to stop you. You don't have to change names for that. Okay? And please don't ये वाला कि ये हो जाएगा ना मैं तब खुश होऊंगा और फिर जब ये मिलेगा तब खुश होऊंगा. Be happy the way you are. Everything will come to you. तो बदल लेना. Okay, so all of you बताओ. Yes, Aisha. Very good. So you all have answered already. I'm just talking and talking. So this is 63 and everybody knows here it will be 64. Am I clear? So if it is 64, this is more power, this is less power. So less power in the vertical means it's an against the rule astigmatism. Right. Let's go to the next one. We come to this most common ocular manifestation of COVID-19. Now, after some conceptual topic, we are here with the factual ones. Very quickly, COVID-19 में दो चीजें याद रखनी है. Most common is, of course, follicular conjunctivitis. No, why are you answering C, all of you? Most common ocular manifestation of COVID-19 is conjunctivitis, follicular conjunctivitis. Don't answer mucormycosis. Why these people have got mucormycosis? Because of injudicious use of steroids and therefore lot of diminution of the immunity. When the immune system has suppressed, the patients have started getting fungal infections. Otherwise, mucor is everywhere. Not everyone is getting mucormycosis. Do you get me? But most common manifestation, please answer. Yes, it is follicular conjunctivitis. And what is the second? आँख में दो चीजें कोविड ने की है. एक ये हल्की मानेंगे फॉलिकुलर और एक सीरियस चीज क्या की है? सेंट्रल रेटिनल आर्टरी ऑक्लूजन. These are the two main effects of COVID-19 on the eye. Right? Okay, let me take also this opportunity to talk about one more very quick ocular complication of one drug which is these days the most popular drug which is these days talked about. Can you all tell me which most popular talked about drug I am talking about? किस दवा की हम बात कर रहे हैं? Most talked about, very popular, used for. हाँ आयशा सही समझे. Yes, I am talking about Ozempic and Mounjaro, and just let me share with you, can lead to a very serious in few percentage of patients, but you don't know even if you're included in that few percentage, is causing ischemic optic neuropathy. Okay, which means irreversible loss of vision because your optic nerve is not working anymore. So please, knock, knock, knock. Please be very, very careful. ओके, सो ये तो बात हो गई ओजेम्पिक मंजारो और ये बात हो गई कोविड-19. आगे बढ़ते हैं. सो व्हाट यू आर लुकिंग आउट है, दिस इज अबाउट योर चेरी रेड स्पॉट. सो कोविड-19 ऑल्सो कॉजेज CRAO, जो कि हमने पढ़ लिया है. दिस इज योर चेरी रेड स्पॉट एंड ये हो गया आपका एडिमा. And of course, it can complicate into mucormycosis. Now, what are the questions that you have to know? Mucormycosis, of course, we know we have to go for, in mucormycosis, amphotericin B, isn't it? And apart from that, if it is in the orbit, in orbital, again we have to go for the same. Mainly the drug is amphotericin B, which acts well. Yeah. DD of cherry red spot, if you all want to revise, first would be blunt trauma, that is your commotio retini. We all know that, है ना? What is the next apart from commotio retini or Berlin's edema? या इसको क्या बुलाते हो? Berlin's edema. So Berlin's edema और commotio retini. What is the next thing? आपको क्या पढ़ना है? CRAO. तीसरा DD क्या पढ़ना है cherry red spot का? वो हो गया आपका depositions. डिपोजिशंस में सारे आ जाएंगे, टे सैक्स, नीमन पिक. मैनी ऑफ यू आर कंफ्यूज कि गाउचर्स है कि नहीं. गाउचर्स इज कंसिडर्ड अ कॉज ऑफ चेरी रेड स्पॉट. ओके, डोंट फॉरगेट दैट. सो ऑल द स्टोरेज डिसऑर्डर्स, यस, वेरी गुड. स्प्लैश CRVO अलग चीज है. स्प्लैश अच्छा, स्प्लैश सॉस अपीयरेंस इज सीन इन CRVO. यस यस यस. Okay, Preeti, you want to know why Berlin's? Because of the same reason as why CRAO. In Berlin's edema, it's a macular edema due to blunt trauma. Again, here, what do you see in central retinal artery occlusion is again an edema. Do you get me? Now, what have you learnt in the structure of the retina? That mainly, what are the layers of the retina? There are 10 layers. But fovea and foveola, the very center of the foveola area, do you remember the structure of the macula? There is avascular zone. And also there are only 5 layers in the foveola area and only 6 in the fovea. So, because of this, we don't see any edema at the very center of the fovea. And because edema वहाँ पे नहीं है, मुझे पीछे से conoid चमक रहा है as cherry red spot. This is the cause for both Berlin's edema and central retinal artery occlusion. और बताओ क्या होगा storage disorders में? All these depositions are in the ganglion cell layer. अब वो ganglion cell layer present ही नहीं है fovea और foveola वाले area में. So if this layer is not there, deposition is not happening there. No deposition there means background choroid is seen as cherry red spot. ठीक है, समझ आ गया? चलो, ये हो गया आपका cherry red spot के बारे में. Now, which nerve palsy? Clarify this. Okay. After this, we are talking about this. Can you all tell me what it is? Tell me. Okay, one of you are asking, what about Madras eye and conjunctivitis? Yes, Madras eye and conjunctivitis are same. Is the name for conjunctivitis, but particularly for viral conjunctivitis. Okay, so it's mainly for viral conjunctivitis. That is the eye flu due to viral infections. Okay. Right, Preeti? Done? आगे बढ़ो. Very good. So this is your cobblestone appearance. What are the questions that will be asked? Cobblestone appearance. What is cobblestone appearance, all of you? These are flat raised areas. This is papillary hyperplasia, isn't it? Now, what are the points that we have to understand for cobblestone appearance is this is a papillary hyperplasia. Okay, first question, this is of course a case of vernal keratoconjunctivitis, right? What is the type of hypersensitivity reaction in vernal? Okay, don't mug up like this, learn with me like this. Make a diagram. So when you say vernal, it is no follicular reaction, only papillary reaction. So if I revise vernal with you, we make this diagram very quickly and we learn there is papillary hyperplasia in the upper palpebral conjunctiva and on the upper limbus. At the upper limbus, there are central dots along with this, and this is what is called Horner-Trantas spots. This is another exam question, Horner-Trantas spots. What are Horner-Trantas spots? आप बोलोगे these are eosinophils. These are eosinophils. This is another exam question. What else have you learned about vernal? If you remember, and that is your shield ulcer. ठीक है? Shield ulcer is nothing but microerosions with deposition of the mucus. That is another exam question. So Horner-Trantas, shield ulcer, eosinophil. What type of reaction is this? It is type 1 hypersensitivity because we have eosinophils, right? And this you have just learned with me as cobblestone appearance. ठीक है? और कुछ भूल रहे हैं हम लोग? Cupid's bow. Again, that is involvement of the cornea. Another thing, if you see a pseudomembrane here, what is that? If there was a pseudomembrane, we will call it Maxwell-Lyon sign. That is what is Maxwell-Lyon sign. So these are some important things you have to remember. Of course, treatment would be anti-allergics and mild steroids. ठीक है ना? Okay. So once we know this, very good. All of you have answered so well. Now we come to next is, yes, it is also called spring catarrh, Dr. VK, but we have to also remember it's more like a misnomer because it's mainly in summers, seen in male children. These are all, and it's an exogenous allergy. Yeah. We come to this one. What is this? We all know these are sago grain-like follicles, and this is what is, we had learned it as trachoma. Isn't it? Yeah. Okay. So, how very quickly again, the trachoma I can revise again in this style only. Add a page here. Let me make another diagram for you all. So, if I talk about trachoma very quickly learn like this. We all know it is chlamydia trachomatis. Revise with me A, B, B and C. Mainly बच्चों की disease है 1 to 9 years. इसलिए कौन सा strain है A, B, B, A and C. ठीक है? Again, what do you get here? What we get here, if this is the cornea, this is the pupil, right? And this is your papilla, and these are the cobblestone appearance in, I'm so sorry. We are talking about trachoma. So it's a follicular reaction. So what you get in trachoma here is your sago grain-like follicles on the upper palpebral and also on the upper limbus. When this is going to scar, the exam question, this is what is your arts line. And when there is a scarring here, we call it Herbert Pitts. This is all asked in the exam. Don't forget your WHO classification, that is FIST O. Another question on trachoma, what is the complication? Complication of trachoma is only one, and that is corneal ulcer. Right? Treatment of choice for trachoma, whenever they ask you, you answer azithromycin. Another thing that we will not forget about trachoma and asked in the exam repeatedly is safe strategy. Okay, I think I have included a question there. We all know surgery, antibiotics, facial hygiene and environmental cleanliness. So these are all important points. Anna, LR6SO4 का मतलब if 6th nerve is gone, it is the lateral rectus is gone. If 4th nerve is gone, it is superior oblique is gone. And if 3rd is gone, rest all the muscles leaving behind lateral rectus and superior oblique is gone. You have just learned with me that in 3rd nerve palsy, the eye is down and out. Now think yourself with me. Let's think together. Okay, let's think together. So when you say 3rd nerve palsy, LR6SO4, that means these two muscles are working. If these two muscles are working, think with me, lateral rectus abducts and superior oblique abducts and depresses. This is the reason the eye is down and out. Okay? Now you got it? How to think about it? एक minute. Actually, the page which I have added has come into that shape now that it's creating a problem. But what I have just written and what is hidden is the topic trachoma, and I have written 1 to 9 years. That's it. Nothing more you're missing. Everything is there. Okay. Yeah. We come to the next one now. Let's solve this question. A 5-year-old boy brought to ophthalmology OPD with complaints of intense itching, photophobia, and ropey. Of course, how could we forget when we are revising vernal keratoconjunctivitis? It's a ropey discharge. Moreover, examination, what it is showing? Cobblestone. So, answer is vernal. So, I think this was simple. We can be a bit fast? Okay, we will be. We come to the next one here. Now, all of you, why are these 3 slides related? Tell me. This is your cobblestone. This is vernal keratoconjunctivitis. This child is itching a lot and getting these folds under her eyes, and these are what are called Denny Morgan folds. Okay, Denny Morgan folds. And what else? What do you see? It is associated, too much of rubbing in a small child can be associated with keratoconus. So this slide will always help you to remember that a case of the vernal keratoconjunctivitis, it is mainly associated with can be associated with keratoconus. Shield ulcer is used in, this is again your exam question, I'm trying to including the PYQs, is seen as we all know, we will be talking about spring catarrh. है ना? Shield ulcer यहाँ पे क्या आंसर करोगे? Spring catarrh. Okay. We next talk about a contact lens. This is very important. Recently asked, you're talking about cobblestone. What about these? These are giant papillae, and these giant papillae, and that also related to contact lens use. So it's a giant papillary conjunctivitis. Yes. Okay. Keep that in mind as well in the DD of this condition. Again here sago grain like follicle. So again your what should be the answer? Chlamydia trachomatis. We have just revised the strain A, B, BA and C. We next talk about is SAFE strategy, which I just told you is the main treatment. S stands for surgery. Okay, one thing I would like to add here. When will you apply SAFE in any area? When the prevalence of trachoma follicles in 1 to 9 years of the population is more than 10%. This is the condition when we apply SAFE. And then they can ask you which surgery and which antibiotics. With surgery, it is your trichiasis or entropion, trichiasis surgery or entropion. Bilamellar tarsal rotation is done. Okay. And which antibiotic? We will again answer azithromycin. Yes, very good. D2K swimming pool. Awesome. Divya, it won't be like everlasting, unending. We are trying to make it appreciably till your attention level is maintained, and so is mine. Okay? Yeah. It's not that I'm going to take for unlimited 4-5 hours. So please relax. When did we start? I think it was supposed to be 11:40. You know? It's roughly 1 hour and little more that we have talked about. So don't panic. Let another hour go. Then we will know exactly when we are going to end. Okay, then we talk about this one. Very, very important topic. I hope you will revise it. What are we talking about? What is this? Answer me. So we started at 11:40, 11:45. Yeah. Because again, there was some technical, and I was not today, please. Thank God it's going on well, touch wood. So tell me, what is this? No, but my question is, what is this? Yes. Yes, Dr. Lithium. Oh my God. This is Bitot spot. Yeah. Exam question. It is more common on which side? You will answer temporal. याद रहेगा? Please revise your WHO grading. क्या था WHO grading? XN is nyctalopia. Another question. Earliest feature of vitamin A deficiency. You will answer your nyctalopia, that is night blindness. Don't forget this, please. Then what happens? So let's revise verbally. 1 AB, conjunctival cirrhosis. B is Bitot spot. 2 corneal cirrhosis. 3 AB. 3A is keratomalacia. 3B is also keratomalacia, but A is less than 1/3. B is more than 1/3 of the cornea, and XS and XF, XS is corneal scarring and XF is xerophthalmic fundus. ठीक है? So revise that. And yes, they have asked you, very important, is treatment. So I hope you know, if the patient is more than 1 year, we are giving injectable vitamin A, 1 lakh international unit on 01/14. एक today 1 injection, कल दूसरा injection और फिर 2 हफ्ते बाद. Okay, and if is less than 1 year, we are going to halve the dose. Right? Okay. So please revise. This is another important question on conjunctiva chapter. We all know we are looking at pterygium. So pterygium ka what is? It is mainly degenerative and not inflammatory. Connective tissue disorder hai. More commonly, next question you answer nasally. Why it is happening? You answer UVB rays. Isn't it? Yes. And which is the most effective way of preventing recurrence? It is always autografting. Autografting. And yes, there is a variant of autografting, and in that variant, that is what is called as, again, Fit Medicos has answered, what is perfect surgery, right? So please revise what is perfect surgery. The question was, it is related to, you answer pterygium. ठीक है? Do you want me to explain what is perfect? So अगर ये आपका suppose यहाँ से pterygium निकला, if you have removed the pterygium from here, what do you do in an autograph? You are cutting a piece of the conjunctiva here. If this is the X and this is the Y, we have to be sure we are stitching X here and Y here. Now, perfect means you are resecting a larger area and creating a bare area, and you have to therefore cover with a larger graft. So here it is seen that if we use this method, then recurrence is almost 0, 0.1%, almost 0. This is what is called pterygium extended resection followed by extended conjunctival transplantation. Okay, extended resection followed by extended transplantation. So simple. Okay, and how do you differentiate a pseudopterygium from a pterygium? Very good. Yes. How do you wait for pseudopterygium and pterygium? How do you differentiate? Glass rod test. You pass a glass rod underneath it. अगर ये आराम से चला गया, pseudopterygium. नहीं जा रहा है, pterygium. Okay? So glass rod test. If it passes easily, क्योंकि pseudopterygium क्या है? एक scar tissue है which is looking like pterygium. It is only adhered to the apex. So passes, it is pseudopterygium. If it doesn't pass, it is not passes. Now it is pterygium. Great. So this was your question. A middle-aged woman is presenting with pterygium that is steadily be progressing and encroaching the pupillary area. If anything is already encroaching, please don't try to remove from there, otherwise will cause an opacity. Wait till it crosses the hole and goes to the other side. So what is the best method if it has encroached? We answer observation. Yes. Very good. Now what are you looking at? What are we testing? Dry eye. So this is your Schirmer's test, isn't it? This is Schirmer's test. In Schirmer's test, we are using Whatman paper 41. We are putting in the lower lid for 5 minutes. If the wetting is less than 5 millimeters, it's a severe dry eye. So revise your Schirmer's test. Now you don't want to wait for 5 minutes. You can wait only for 15 seconds. You just use a phenol red thread. Phenol red thread में आपने thread को phenol red से coating कर दी. So phenol red thread test में क्या किया आपने? You have coated it with phenol red. And after coating with phenol red, now you wait for 15 seconds. Due to the change in pH, there is a change in the color. It becomes orangish. If it is less than 9 mm, again it's a severe dry eye. नहीं, phenol red में it is not 5. आप phenol red में आप याद करोगे less than 9. चलो एक और सवाल आप जवाब दो. A patient has significant distress on reading text of paper or screen. When I read the first sentence, I feel अच्छा कुछ accommodation पे सवाल है क्या? But then it says on examination of his eyes, all domains including visual acuity are essentially normal. And except for Schirmer's test, which is 5 mm, what is the best way to treat? We are answering lubricants. Yes. Okay. Now we come to this one. What are you looking at is the different layers of the retina. है ना? So if I talk about the different layers of the retina, सबसे outermost of course choroid के बाद outermost layer क्या होता है? Pigment epithelium. So this is your pigment epithelium, right? After this layer is the layer of rods and cones. This is the layer of rods and cones where you see the outer inner segment. And then outer nuclear is again nucleus of rods and cones as outer nuclear layer. This one. So you should know the histological diagram can also be asked, though it is not asked in FMG. Then outer plexiform. Outer plexiform इसी का जो है nuclei का axons, and then inner nuclear, which is mainly what? You should remember, outer nuclear तो photoreceptor होता है, inner nuclear क्या होता है? Bipolar cell, amacrine cell, horizontal cell. ये सब हो गया inner nuclear layer. Then comes the inner plexiform, then ganglion cell layer, which has ganglion cell and optic nerve. Okay, Twilight, I will only speak in English. Relax. I am immediately converting it into the English, but I will only speak in English. You just please focus. Please relax. Okay? So now you got up theek hai can come out, but normally it will only be in English. So now we are talking about these are the different layers. I hope you are clear with this and you have revised these layers. It is very important. If you want, we can revise in our style. It will never be difficult and you will find the whole thing very easy. Very quickly, if you want to make, this is your outermost, which is your retinal pigment epithelium. Then comes your space. This space is called subretinal space. And then we have your layer of rods and cones. It's a simplified diagram, guys. This is a single line of rods and cones. Then comes your external limiting membrane. Then comes your outer nuclear. Then every line is a layer. Outer plexiform, inner nuclear. Inner plexiform is nothing but your, yes, axons, dendrites of the bipolar and amacrine and horizontal. And after inner nuclear, inner plexiform के बाद क्या आएगा? Ganglion cell layer. Ganglion cell is also, उसका dendrite is synapsing with axons of the bipolar. Ganglion cell के जो axons होंगे, they are going to aggregate and form the nerve fiber layer. This is the nerve fiber layer, which will all from the whole retina, the nerve fiber is aggregating to form the optic nerve. You all know that. Then comes your nerve fiber layer and internal limiting membrane. You know, this is your internal limiting membrane. This is the condensed part of the vitreous and this is your lens. Anti-say. So this way if you learn, it becomes easy. Another important thing, the blood vessels are at two levels, OP and IN layer. These are perpendicular to the surface of retina, and along the nerve fiber layer, they are parallel to the surface of retina. So दो level पे आपको blood supply याद रखना है. Any bleeding here is a dot and a blot. Any bleeding here is a flame shaped hemorrhage. Okay, Preeti, okay. Done. Sure. Right? So once you know this, then you also know that outermost is your retinal pigment epithelium and the rest of the layers are from, which are apart from this, what are these called? These are called as neurosensory retina. Everyone is clear what is retinal detachment? Separation of this layer from the neurosensory retina. Why? Because it is the subretinal space which is embryologically very weak. And of course, outside you can draw with me. This is what is your choroid. This is what is your choroid. अच्छा हर्ष, अभी हम लोग we will revise the ERG waves, don't worry. I will revise with you. If I miss, you will remind me again. I won't miss वैसे. ठीक है? So, is it okay? Is it done? This is the basic, we know, understand? So, you have to be very familiar with the different layers of the retina for exams and you should know each layer has what. So, is there still a confusion? Can we revise together? Retinal pigment epithelium, in rods and cones, there are outer segments of rods and cones, and then it is the outer nuclear layer has nucleus of rods and cones. है ना? And then we have learned that when you talk about the inner nuclear, it has bipolar cells, bipolar, then we have horizontal cell and amacrine cell. Clear? Okay. So be very, very clear with the basic structure of the retina. We come to the next one. So we just learned that retinal detachment is separation of the neurosensory from retinal pigment epithelium. You should be able to see the different retinal detachments. What are the three types of RD? One is, if you look here, this is a convex configuration. This is your exudative. है ना? So exudative RD, what is very important and can be asked is shifting fluid. Right? Then we talk about if there are traction bands. We are talking about tractional retinal detachment. Right? And then comes your, what are you looking out here? This is your OCT, and this is edema, right? Intraretinal edema. And the OCT is showing if this was your retinal pigment epithelial layer, and this is whole thing is your neurosensory retina, right? So what do you see here? Neurosensory retina is this. So this space is all the subretinal space, and there is a separation. So this is what is shown is retinal detachment in the optical coherence tomography. Okay. So what is the next type? This where you can see a giant tear, and this is what is called giant tear is what is your rhegmatogenous retinal detachment. This is, just remember, this is rhegma means break, and this rhegmatogenous is the most common type of retinal detachment. And typically a patient with rhegmatogenous will feel something like this, as if a curtain is coming in front of the eyes. Okay. So this curtain falling in front of eyes is typical for rhegmatogenous. In front of eyes. Okay. Okay. Now, also one more important thing which we can discuss when we come back to this diagram is when all the vascular pathologies, one of you have written, na? Yeah, Fit Medicos has written for traction and diabetes. So I just was reminded to revise this with you all, that when you talk about the different vascular conditions of the retina, if you are familiar with what is the exact pathogenesis, the whole chapter becomes very easy. So please just understand, very simple. This I keep teaching you. It's a very, very simple way. The main problem, whether it is diabetes, hypertension, central retinal vein occlusion, sickle cell anemia, etc., etc., main problem and culprit is hypoxia. And whenever there is a hypoxia, there will be increased capillary permeability. And this causes leakage. How does this leakage is seen in the retina? As edema, as exudates, as hemorrhages. Now again, this leakage is exacerbating or increasing hypoxia. It becomes a vicious circle. What next happens is this hypoxia further increases, and when this happens, now there is a release of chemotactic factors, and this release of chemotactic factors will lead to neovascularization. This neovascularization is seen as NVD and NVE, okay, at disc or elsewhere. Okay, so this release of chemotactic, we all know mainly we are talking about vascular endothelial growth factor. At your level, we don't need to learn the list or anything. Just remember vascular endothelial growth factor. So this causes release of chemotactic factors will cause neovascularization. If you go back to here, what is happening? This neovascular, suppose here these are the new vessels. They are very leaky and they are associated with fibrous tissue. So what will happen if they are leaky? It bleeds and it leads to vitreous hemorrhage. If there is a total vitreous hemorrhage, light ray is not reaching the retina, I cannot see. What next is happening? Because of this fibrous tissue, it contracts, pulls the retina, leading to tractional retinal detachment. What third thing can happen? This hypoxia may actually cause neovascularization in the iris. And any rubeosis iridis, if there is any rubeosis iridis, this rubeosis iridis will lead to neovascular glaucoma. ठीक है. So what we have to understand that there can be 3 blinding complications of this neovascularization. What are those? These 3 blinding complications are vitreous hemorrhage, tractional retinal detachment, and neovascular glaucoma. Okay, so this whole story, we can put one name in my style just to make your life easy. We call it retinitis proliferans. So we are calling it retinitis proliferans. Okay? Okay, so your basic is now strong. We can move further. So this is again a question on retinal detachment. A 61-year-old professor presenting with loss of vision in left eye describes a sensation as curtain drawn in front 7 days ago. He gives a history of having cataract surgery in the same eye 3 weeks ago and a B scan was done. And here you go. This is all retina, which is the detached retina. Okay, so this is a case of retinal detachment. Yes, the answer will be C. Okay. Yeah. Another question is this one. A 60-year-old diabetic male is presenting with history of decreased vision. Angiography is showing the image here. Now tell what is the most likely diagnosis. So all of you, let's look at the angiography. What do you see in an angiography? Is there any hyperfluorescence or hypo? Hyper kab hoga? When there is leakage, isn't it? And hyper, just remember, hypo is when there is a block. Mainly we have to talk about leakage and block. So I can see multiple dot. These are microaneurysms, but I also see a tuft of new blood vessel here. So this is what is NVE. And because there is NVE, we will go say it is a neovascularization, that is proliferative diabetic retinopathy. Okay. So this is PDR. So all of you, a quick revision here. We all have to remember our classification of retinopathy. The old classification which says you can divide into background, pre-proliferative, proliferative. What is background? Microaneurysms hai, edema, hemorrhage, exudate. This is background. Then, agar along with the background, you have more number of cotton wool spots, you have larger blot hemorrhages, you have looping and beading of vessels, you have intraretinal microvascular abnormalities. All these will suggest it's a pre-proliferative, means hypoxia is now more. And when there is proliferation, neovascularization, either at disc or elsewhere, this is your proliferative DR. If there is a neovascularization, this is proliferative. Right? So, coming to the newer classification is the ETDRS. I want you all to revise this as well very nicely. It is divided as non-proliferative and proliferative. Now, when you talk about non-proliferative, this is either very mild, mild, moderate, severe, very severe. Very mild, mild. Moderate, severe, very severe. Easy? Okay. So, what is very mild? When there are only microaneurysms. So, this is an exam question. What is the earliest feature of DR? So, earliest feature of DR, what should you answer? We will say only microaneurysms. Okay? Right? So, please revise this. It's very, very important. When you say mild, it is along with this, we have hemorrhage and exudate. Just revise your ETDRS classification. Moderate is all the features of pre-proliferative stage. Right. So, then next we talk about is, here you are, these are the different stages. You should be able to see the fundus. What do you see here? I can see hard exudates, I can see hemorrhages. So, what are these? This is which type? It will be mild. That is background diabetic retinopathy, or you can call it as mild NPDR. They have asked you sometimes to label it. So, these are what are called your hard exudates. Okay? Yes, very good, Dark Medico. फिर again Dark Medico. You are changing the name, na? Are you changing the name? Change it. Okay. I'm not saying it to many people have, मैंने बोल दिया तो कर लेना, कुछ नहीं होता, कुछ अच्छा bright सा रख लेना. Anyway, so what we have to understand, what was mild? Mild was, बताओ, revise करो. Mild was, what did I just teach? Mild is all the features of background diabetic retinopathy. Moderate हो गया pre-proliferative diabetic retinopathy. ठीक है? This is what it is. And then comes your severe, and very severe is 4:2:1 rule. Please revise this. Again, if I am dividing the whole retina into 4 quadrants, hemorrhage and microaneurysm in all 4 quadrants. I am verbally revising with you all. What is 4:2:1 rule? Hemorrhage and microaneurysm in all 4 quadrants, or looping in any 2 quadrant, or IRMA in any 1 quadrant. Just read it, okay? Any one criteria, it is severe NPDR, but if it is more than one criteria, it is called very severe NPDR. Yes, thank you. Yes, after the session. Okay? Okay, then we talk about, we are back here. This is what is looping. You should be able to see what is looping. This one is your looping. These are blot hemorrhages, right? So we are looking at pre-proliferative stage or moderate NPDR. You should be able to understand this. These are multiple cotton wool spots. It's a pre-proliferative stage with hemorrhages, all types. And what is this? Angiography with microaneurysms. So it's a mild NPDR. I'm not sure it is mild because I can see some blocked fluorescence here. It could be just some hemorrhage. So we will just say it can be. So it's not very mild. We will just call it mild. That means these are what? Microaneurysms. So we will say it is a mild NPDR. Okay? Yeah. What is this? Here I can see neovascularization. So this one is proliferative diabetic retinopathy. So here we will say this is proliferative diabetic retinopathy. I hope you are able to recognize all the features. This is your cotton wool spots, right? These are the hard exudates. Blot hemorrhage. This is flame shaped hemorrhage. So you should be able to recognize this, right? And again, this angiography is showing you this all neovascularization, microaneurysm. So it's a case of proliferative diabetic retinopathy. Yes. We next talk about this one. All of you, very important for your exam. Somebody was asking something on CME. Suddenly I remember. There was one question. Can you all repeat the question? What was that question? What is the treatment? Shivangi, what is the treatment of CME? CME treatment is, it is mainly indomethacin eye drops, NSAIDs, and mainly your C inhibitors. Okay. So what do you give? What do you see here? What do you see here? This angiography is showing you what pattern? It can be an exam question. This slide. So this is what is flower petal pattern. Because it is flower petal pattern, this is a case of cystoid macular edema. Very good. So CME, all of you, what question they have asked you? Irvine gas syndrome, which is CME after cataract surgery. If it occurs as a complication after a cataract surgery, we call it Irvine gas syndrome. And what are the drugs that can lead to CME? Epinephrine and niacin. They can cause CME. Remember this. Okay? Yeah. What are you now looking out? This is what is? Can you see a big circle and then the leakage? So that big circle is your mainly shallow retinal detachment of CSR. So what you're looking at here is ink blot pattern. Ink blot pattern. And ink blot pattern is a feature of central serous retinopathy. Right? Okay, we have an example. Okay, CSR, all of you. Central serous, you can also get smokestack pattern. If in the acute stage, it is always self-limiting. Don't forget. Just revise your CSR as well. Chalo, let's solve this question here. A patient is presenting with vision problems and has a history of cataract surgery. Yes. So I think we have just said it is Irwin gas. I can see these cystoid spaces on OCT, isn't it? These are cystoid spaces which are seen here. Spaces वही होंगे ना जहाँ पे edema कहाँ होगा? Where there are blood vessels. What did you learn? Where are the blood vessels? कौन सी layer में? OP and ion layer and along the nerve fiber layer. So don't forget that. Very good. Now we are back to a CSR. To revise CSR, what is the other thing? On examination, what type of thing you get here? This is your ring reflex. So what we are getting in CSR, this is your ring reflex. Okay. And this is on OCT, just fovea ke area pe detachment. Okay. So only the foveal detachment. I think it's a chronic case because some retinal pigment epithelial area is also being disturbed. RPE bhi detach ho raha hai sab. So it can be chronic CSR where retinal pigment epithelial cells also get affected. Then very important, how does it present CSR? Mainly disturbance of vision. What test is this? All of you, this is what is Amsler grid. Very good. So Amsler grid is showing us two things it can show in CSR. One is your micropsia and another is your distortion of image, which is called metamorphopsia. So distortion of image is metamorphopsia. Okay? Okay. What is this? I think we have done already. Very, very important. Repeatedly asked in the exam. This is a case of central retinal artery occlusion. We see attenuated blood vessels, edema, cherry red spot. Right? What is the main cause of CRAO? Embolism. What can be the main emboli? Don't forget about Holland-Horst plaques. These are cholesterol emboli. What can be the other cause? Other cause can be your mucormycosis. Yes. Another cause can be mucormycosis, a cause of central retinal artery occlusion. Good. What is this indicating? Very important. 14% of the population has got a dual blood supply on his macula. So this another artery which can supply. So in a CRAO, this supply is being maintained here, which is only supplying the papillomacular bundle. So this patient will have central vision and a little field is only left around the central. What is this? It is also called tunnel vision. And which artery is this? All of you? What happened, Preeti? Oh my God, I'm afraid. What happened? What happened? What you could not understand? So this is actually cilioretinal artery. So population, some people have double blood supply in the macula. So the second artery which is supplying here is cilioretinal. By chance he has manlo occlusion of his central retinal, but his cilioretinal, he is lucky enough to have cilioretinal artery, then he can retain his central vision and some amount of field around the central vision. Now is it clear? Preeti, please clarify. Is it now clear? I think I'm talking in English only, no? Did I by mistake again talk? It's not smiling, Preeti. This emoji, it should be some more pleasant smiling. Isn't it? Okay. So this is your cilioretinal artery. I hope you are clear now. This is important, can be asked. Right. So you have this question on central on cherry red spot, that fundoscopy is showing this image. What is the most likely diagnosis? Of course, here we should answer. If this is the image and we are not very sure, then anything, cherry red spot, it can be anything. No, BRVO will be mainly at one quadrant. Na? It cannot be all around. You won't see splash source appearance. You are not seeing all those changes around the disc. You're only seeing in any one quadrant, and most commonly it is the superior temporal quadrant. Okay? Yeah. We next talk about, okay, we were talking about this only. For a long time, you all have been talking about this. So this is what is splash source appearance, where there is multiple flame-shaped hemorrhage around the disc. So splash source appearance is a feature of CRVO. Can you remember any other important question regarding CRVO? There's one more important question, and that is 100-day glaucoma. Some books say 90-day, both are same. What is this? Did I not just teach you about the pathogenesis and retinitis proliferans? What is that? So, in a patient of central retinal vein occlusion, it is seen that the complication of neovascular glaucoma can happen exactly after 90 or 100 days. So, it is nothing but neovascular glaucoma in CRVO. This is what is called 100-day glaucoma. Got it? Yeah. Okay, can you tell me, can you name what this slide is? Can you name the diagnosis here? Preeti, where are you? Name the diagnosis. I'm taking 1 second to just switch this off. Wait a minute. Name the diagnosis. Yes, Harsh, very nice. It is pathological myopia. Why? Because we see retinal changes in a pathological myopia. What are the changes that you can see here? We can see here these lines are break in the Brooks membrane. We call them lacquer cracks. What else I can see? I can see prominent blood vessels, which we also call tigroid fundus or tessellated fundus. Isn't it? Then we can see the atrophy around the disc, and this is what is called annular crescent. Right? So these are lacquer cracks. And what is this, guys? I can't see the central retina here. What is this? This is mainly the periphery of the retina, and what we see here is lattice degeneration. So this is your lattice degeneration. Shivangi, there's a lot of difference between hypertensive and diabetic retinopathy. First of all, what is the normal AV ratio? In a hypertensive, you have learnt about Keith Wagner grading. What was that? Grade 1 is generalized attenuation of vessels, mainly the attenuation of arteries. That will be the first thing to happen in a hypertensive retinopathy. Slowly there can be hemorrhage exudate, right? And then last may papillary edema. If I talk about hypertensive. So what should be the first change? Disturbance of AV ratio. What is the AV ratio that you know? A normal AV ratio? Normal आपका artery is to vein ratio is how much? 2:3. So it can become 1:3 or so. Then also it's more theoretical, but if they ask you this way, mainly splash source hemorrhages will be flame shaped hemorrhages would be more common in hypertensive. Okay, that means NFL layer mein zyada hemorrhage, and also soft exudates in case of malignant hypertension. Because of the severe hypoxia, you may get soft exudate. The pathogenesis is same. Now, if I talk in terms of pathogenesis, Shivangi, think with me. If you have come back to your common pathogenesis, what did you learn with me? Hypoxia, increased capillary permeability, leakage, which is again causing more hypoxia. More hypoxia is causing chemotactic factors and neovascularization. This is what you learned. Now, what you have to understand, in hypertensive, hypoxia is never so much that there will be release of chemotactic factors and neovascularization. What is happening, everything will be above that line which I drew. Okay, but in hypertensive, it can lead to severe complications like vitreous hemorrhage, traction retinal detachment, and neovascular glaucoma. If it is purely diabetic retinopathy, no, not in hypertension, I mean to say in diabetic retinopathy, you can get severe complications, that is NVH, vitreous hemorrhage, NVG, that is neovascular glaucoma, and tractional retinal detachment. This will not happen if it's only hypertension. And if it's only diabetes with no hypertension, AV ratio will not be disturbed. Okay? So I think now it has helped you. If you go back to your common pathogenesis, things will become easy. Okay, Arvind. What should I say? शिवांगी, वॉज इट हेल्पफुल? ठीक है, समझ आ रहा है? अन्ना, ट्रू रोजेट एंड सूडो रोजेट का मतलब है, द मीनिंग इज, in true rosate you have a central lumen, that is flexner winter steiner. In a pseudo rosate there is no central lumen. That is the difference. Great, Shivangi. So we move to the next slide. What are you now looking? Again, it's a pathological myopia, and what I can see here is chorioretinal atrophy. Okay, so this is chorioretinal atrophy. I want you all, now this one you will actually answer me. You are looking at a ultrasound B scan. I hope you know how to look at ultrasound B scan. This becomes the lens wala part. Okay, this is your vitreous and this is the retinal at the posterior part. So what are you looking at? What is the abnormality here? Can you all answer me this? Yes, obviously we are talking about retinoblastoma. Yes, you mean to say posterior staphyloma, right? So because this can be very clearly seen here that this is, instead of going like this, it is coming like this because there is ectasia and posterior staphyloma. Okay, so this is a feature of pathological myopia. It has been asked many times. Okay, in myopia the eyeball is extending and posteriorly then it gets ectatic. This is what is posterior staphyloma. Am I clear? Important exam question. And which is the most common type of staphyloma? Again, it is posterior. Remember. Yeah. Next, we talk about this slide. Can you tell me what is the diagnosis? What I see at the macula is alternate areas of hyper and hypo. Yes, this is bull's eye. Hyper, hypo. It looks like an eye of a bull. We are talking about bull's eye maculopathy. This is bull's eye maculopathy. Yes. So when you say bull's eye maculopathy, guys, tell me, what are the differential diagnosis of a bull's eye maculopathy? So number one you will answer is chloroquine. This is ours. Second is your hydroxychloroquine. And remember one more, and that is your cone dystrophy. Okay? Cone dystrophy. So chloroquine, hydroxychloroquine and cone dystrophy. Okay, we come to this one. What are you looking at? What is this? Answer me. Name the sign. Yeah. It's a white eye reflex called leukocoria. Okay. Most common cause of leukocoria, guys, you should answer. Most common cause is congenital cataract. If I talk about most common cause of leukocoria, you should know all the causes and DDs of leukocoria. Let's revise it verbally. What were the different DDs of leukocoria? Think yourself, what can be the cause where the pupil can shine white in a small child? So it could be cyclitic membrane, it could be fungal endophthalmitis, it could be just your central retinal detachments, Coats disease, PHPV. Okay, so just revise your differential diagnosis. Of course, here we are looking at a patient of retinoblastoma. You can see this tumor, cauliflower-like growth in the retina, and this is the USG-B scan showing you the retinoblastoma. And if you really look particularly here, these white, these are nothing but calcifications, which is important to remember that retinoblastoma can be one of the causes of intraocular calcifications. है ना? Yeah. So let's not forget this. Everything in and out about retinoblastoma has to be revised. Okay, Anna. So this is what you were asking. Pseudo rosates and true rosates. Here it is in front of you. If there is this central lumen, if this is the central lumen, this is the central lumen. Okay. So this is your true rosate, and if this is true rosate, this is what is called flexner wintersteiner. Okay. Another form of differentiated tumor cells that you can see in retinoblastoma is this one. There is no central lumen here. This is what is called, can you see the difference? So this is your pseudo rosate, and in a pseudo rosate is what is called Homerite. We call it Homerite. Yes. And these are called fluorates. These are fluorates. So now it's absolutely clear to you all what is the difference. We come to this question. A 3-year-old boy has been observed by his parents to be increasingly being clumsy for past 6 months. Look at the age of the child, 3 years. Physical examination, cauliflower-like growth is already seen. There is leukocoria and pathology is showing you Wintersteiner. Causative gene. I think we are talking about what is the gene responsible for retinoblastoma. We all know it is RB gene. Where is it located, guys? 13q14. Please don't forget this. So how do you draw that? Just making life simple for you. This is chromosome number 13. Q is a long arm. P is a short arm of any chromosome. It is long arm, that is 13q, and it is the 14th band where there is a problem. This is leading to retinoblastoma. Yes, Shivangi. Shivangi, if there is any mutation which is outside this 14th band, then this child can also have some dysmorphic features. What are dysmorphic features? Like frontal prominence, broad nasal bridge. So this is what is called, if it is together called, it is called 13q syndrome. This together is called 13q syndrome. So one more extra point here. Okay, we come to this slide. What are these? If I ask you, give the heading to the slide, what is the heading? Think. It's always sarcoidosis is a granulomatous pan-uveitis. It's a pan-uveitis, no confusion. I think I've taught you all, made a diagram of what can be the effects of sarcoidosis in your eye. Do we have a clean page? Okay, I'll just create one. Wait. Sarcoidosis. क्या क्या पढ़ा था आपने sarcoidosis में? If you draw a diagram, you can get sarcoid nodules on the sclera or episclera. Make the diagram. So granulomatous nodules are also called here sarcoid nodules, with that is on the episclera and on the sclera. What else you can get? Let's think. In the cornea. What have we learned about the cornea? I don't remember. You can get interstitial keratitis. Remember? Interstitial keratitis. What else? In sarcoidosis, there can be hypercalcemia leading to band-shaped keratopathy. What else? In uveitis, you are getting granulomatous pan-uveitis. And if you remember, in the retinal involvement, we have learnt about, if this is the retina we draw here, we have learnt about your, what do you call that? ऐसे ही देखो, ज़्यादा अच्छा दिख रहा है. So, these are your segmental venous sheathing. What do you call this? Candle wax drippings. This has been also been exam question. Now you will never forget about sarcoidosis. ठीक है? चलो, very good. So we come to this one. What is the heading of this one? I haven't got it yet. These are the types of optic atrophy, guys. So what we have learned, if you remember the diagram, I teach you like this. If these is the types of optic atrophy, this is chalky white in color and clear disc margin. This is primary optic atrophy. Okay, primary means you can't see the cause inside the eye, either it is in the brain or any retrolaminar area. And when you see that no, there is papillitis, papilledema, and that is leading to atrophy, it comes to like this. This is your secondary optic atrophy. So revise your classification of optic atrophy, please. And how did I teach you? Secondary means blurred disc margin. You can see some blurring and the pale area. We call it dirty white in color. So this is the part involved. This is the part involved. Rest of the part abhi nahi involved hai. So this is dirty white and blurred. There is blurring and it is dirty white. This is your secondary. Secondary means after papillitis or papilledema. Third, your learning is this is what is cupping that one of you have just said. Cupping of the disc is around 0.8 or 9. This is nasal shifting of vessels. So this is your glaucomatous. And what is the fourth type of optic atrophy? That is your retinitis pigmentosa macula due to any retinal disease. This is called consecutive. So answer of this question, type of optic atrophy, it will be consecutive. So there are four types: primary, secondary, and glaucomatous and consecutive. You're most welcome, Fit Medicos. ठीक है, समझ आ गया? चलो. So do revise it, please. So now look at this one. What do you see? There's one question here. Okay, first of all, what is it? Can you see the dilated blood vessel? Mainly the veins are dilated and there's blurring. First sign of papilledema is venous dilatation. Okay, so it's a papilledema. Any papilledema will lead to which type of optic atrophy? So it is showing you the secondary optic atrophy. I think now it will be absolutely clear to you. There's another question in papilledema means too much of edema around the disc. What is the field defect? Think yourself, there is pathology around the optic disc. Optic disc is in the field is nothing but blind spot. So what you will see here? Enlargement of blind spot. Okay, so in papilledema what we get here is enlargement of blind spot. Great. We come to the next slide. Please revise your lesions of visual pathway very, very nicely. Okay. So we all should first revise this. The visual field, this is your left, this is your right. Left ka left, right ka right. This is how we see. Okay. And of course, retina ka projection is opposite. So if this is the nasal side, it is giving the field to this side. This is your temporal is giving the field to the nasal. This is what this color coding is explaining you. We all know that the nasal fibers decussate. So A, whole optic nerve is gone. If whole optic nerve is gone, in that case, I will get blindness on that side. If there is nasal fibers are decussating, I am getting bitemporal hemianopia, that is seen in B. Because if nasal fibers are gone, it is temporal field effect. Temporal is gone, nasal field effect. It's always the opposite. We will not forget this. Okay, what happens in C? One eye temporal, one eye nasal. We are taking an example of right-sided lesion here. So it's a right temporal and left nasal. So what type of hemianopia? Homonymous. कैसे होगा? Left का nasal जाएगा या right का temporal and left का nasal. Right? So it should be field effect. Left temporal is gone, right nasal. Opposite होगा ना? So this is what is your homonymous, where the defect is on the same side. Is it left homonymous or right? Defect is on the left side. Lesion will be on the right, but defect will always be on the opposite. So right-sided lesion is leading to left homonymous hemianopia. Hope this is clear. And then we have the next is what happens again if the whole posterior part of the radiation is gone? Same homonymous hemianopia. Cortex is gone, again the same, but there is some more additional things that we have to revise. Let us see one by one. So, okay, let me put it here in this only. It will be easier if I put it in this diagram. So, what I want to say, some fibers in the optic radiation are traveling through temporal, some through parietal, and finally it comes to this point which is posterior part. So, if only temporal fiber, if there is any lesion in the temporal lobe, what is the field effect? If any lesion is a parietal lobe, what is the field effect? First of all, this is one thing you have to add in your knowledge. And secondly, what happens if there is a cortical lesion? This is the second thing that we will revise. Right? Okay. So, we have to learn here that first of all, I said, if I very quickly make the diagram, if any one of you are actually getting confused, please don't. So, we are equally dividing into nasal and temporal. These are the two retinas. Nasal fibers decussate, temporal does not decussate. Right? And we are saying this is the lateral geniculate body. And then optic radiation, some fibers parietal and temporal. and finally they reach the visual cortex, parietal, temporal, and finally they reach. Okay, so we are talking about the anterior part where it is going from temporal parietal. Please remember, if it is a temporal lobe lesion, the fibers passing through temporal lobe are inferior fibers, and therefore the field effect would always be superior quadrantopia, and this is what is called pie in sky, right? And vice versa, if it is a parietal lobe lesion, अब इसमें the superior fibers are passing through the parietal lobe. When there is a damage of superior, you get inferior quadrantopia. This is what is called pie in floor. Correct? So we will not forget pie in sky, pie in floor. Sky, temporal lobe, floor, parietal lobe. Very good, Ayush. Right? Is it clear to all of you? What is congruous and incongruous? Incongruous is not in continuity, congruous is in continuity. So please remember, giving you a tip here from this diagram, that if I draw a line here where it is showing you the posterior part of the parietal lobe, posterior part of the optic radiation can lead to anterior part, so I have just said temporal and parietal lobe. Posteriorly, the optic radiation will lead to homonymous hemianopia. I am drawing a line here. That means posterior part of the optic radiation and the visual cortex, right? This is what is congruous. And everything anterior is incongruous, means asymmetrical field effect. Congruous means symmetrical field effect. So congruous is symmetrical and this is asymmetrical. Okay, got it? Yeah, we'll come to that. Macula sparing, wait a minute. So if you, I'm just making you learn one by one. Now if you look here, what do you see? I see that if I have to complete the circle, this should be completed like this and this should be completed like this. That means left-sided homonymous hemianopia. So this is your left homonymous, it is homonymous. And one more thing that you have to be very clear about. When you say homonymous, it means field effect is on one side, correct? Now, if one is, what about this one? Bitemporal hemianopia. One is on the left and one is on the right. So this is what is called heteronymous. So remember, the only lesion which is heteronymous is chiasmal lesion. So this is what is heteronymous hemianopia. Right? Okay. What is the field effect here? This one is right homonymous. This time the lesion is on the right side. This becomes your right homonymous hemianopia. I hope now you are absolutely clear what we are saying. If you just understand the basics, that field effect is opposite of anatomy. If nasal is gone, there will be a temporal field effect. If superior is gone, we get an inferior field effect. Then you will understand the whole thing very nicely. We come to the next. This is your question. Incongruous homonymous, that means it's anterior lesion with vernix hemianopic pupil. It's a tract lesion. Don't forget, it's a tract lesion. What is hemianopic pupil? When I'm looking at the patient's pupil, I show the torchlight from one direction, I see normal reaction in both eyes. I change the direction of my torchlight, no reaction on both sides. This is called hemianopic. Half of the pupil is working, half is not. Why? Let's go back. Look here. Look at this diagram. Pay attention, please. If suppose, for example, there was a tract lesion like this. Do you realize if there is a left optic tract lesion, there is a lesion here. It is the left-sided temporal is gone, so temporal this is not working and right nasal is not working. Agreed? Now if suppose this is my torchlight. Okay? Are you alert? I am showing this torchlight from this direction. It will fall on the nasal part of this and temporal part of this. So when I am showing on this direction, I see a normal light. But when I change the direction of my torchlight, अब मैं इधर से show कर रही हूँ. If I show from the other side, the light is falling on these cross parts, on the part of the retina which is not working. So no reaction. So from one side, normal reaction, one side, no reaction. This is what is hemianopic pupil. It's a feature of tract lesion. So very important, be alert. Why it is not a feature of radiation or cortex lesion? The same one eye temporal, one eye nasal is going down. Because pupillary light reaction, go back to your pupillary reaction and think. It never goes down. The pupillary light reflex from here will deviate into pretectal nucleus and finally to Edinger-Westphal nucleus. Okay? So this is the reason. Okay. Right, guys. So this was about your question here. Now can you tell me what you are looking at? Can you answer me what is this and what is this? What is the field effect, guys? And where is the lesion? Fast. Field effect and where is the lesion? Yes, very good. It's a chiasmal lesion. What we see is a bitemporal hemianopia. So it's a chiasma. So if you have to answer accurately, you should say central chiasmal lesion. It's a central chiasmal lesion. So, little more. If it is central lesion in the chiasma, I get a bitemporal. The lesion can also be a junction of nerve and chiasma as seen here. Now what is happening? Some fibers of left eye nerve is gone, so I am getting a centroscotoma. When chiasmal fiber is gone, I am getting superotemporal quadrantopia. Right? This is not a central lesion. And what do you call this? This is called junctional scotoma of trocar, or we call it, this is the junctional scotoma, means at the junction of nerve and chiasma, or we call it anterior junction syndrome. And when you say this, what fibers are damaged? This is the normal anatomy. If you look at this one, it is these inferonasal fibers, they detour on the other side and then go down. Now the lesion is somewhere here. Inferonasal fibers are gone. What will be the field effect? Just the opposite, superotemporal. So that is why you're always getting a superotemporal field effect. Okay? Are you all there? Yes. So this was about your central chiasmal lesion. Learn with me: bitemporal hemianopia, anterior junction syndrome or anterior chiasmal syndrome. What will you get? One eye central scotoma, or sometimes even blindness if all fibers are gone. So one eye is this. Other eye, superotemporal quadrantopia. And why it is a rule it's always superotemporal? Because inferonasal fibers are involved. What is that called? Inferonasal fiber which is detouring on the other side. What do you call it? Anterior Wilbrands knee. We call it anterior Wilbrands knee. Good. Okay, what else is important and we have to learn? A patient with pituitary adenoma. We all know above the pituitary gland, chiasma. Compressing the optic chiasma now presents with loss of visual field. What is the field effect? Definitely what should your answer is? Bitemporal hemianopia. Yes. And which anti-tubercular drug causes red color vision defect or optic neuritis? We will remember first always ethambutol. Yes. So if I talk about drugs which is causing optic neuritis, what is that condition known as? Toxic amblyopia. And what are the drugs which are leading to toxic amblyopia? Partial loss of vision due to optic neuritis caused by taking these drugs. This is what it means. So what can be the causes of toxic amblyopia? Always first number pe ethambutol, or maybe something else. Tobacco. First number should always be tobacco. This should be second number. First is tobacco. Okay. Then comes your ethambutol. Then comes your chloroquine. What else? Ethyl alcohol. And finally, methyl alcohol. Ethyl alcohol and methyl alcohol. Okay? Okay. Now this is what I think this is done already. What is this? Pie in sky. If it is pie in sky, so where is the lesion? It is temporal lobe lesion. Temporal lobe is involved and this is pie in floor, which means parietal lobe lesion. Parietal lobe lesion. Very good. Okay, patient was diagnosed with stroke and his visual field testing revealed macula sparing homonymous hemianopia. So we come to visual cortex lesion or occipital lobe lesion. And what is this macula sparing means? You have to understand that this visual cortex is supplied by two arteries, posterior cerebral artery and middle cerebral. Cerebral. Middle cerebral artery M for M supplies the macular area primarily. Therefore, when there is a blockage in the posterior cerebral, macula is spared. Means this area, this is not affected, and this homonymous hemianopia with sparing of macula. This is what we call macula sparing. Recently asked question hai. Okay, so you should be clear, it's a feature of visual cortex. Macula sparing homonymous hemianopia. Okay. Yes, let's revise this as well. Now, what are you looking at? When the light is shown in this patient, what happens? There is a very sluggish or no reaction. Everything is sluggish here. Tell me what it is. When we show a near stimulus, it converges and there is meiosis. I remove the finger, but this is still meiotic, sluggish, है ना? Tonic pupil. So we are talking about Holmes-Addy pupil, which is also called tonic pupil. So please revise your pupillary, abnormal pupillary reactions. Right? So when you say tonic pupil, mainly where is the lesion? Efferent pathway. सबको याद है pupillary light reflex pathway में verbally फटाफट revise कर रही हूँ. जब light, when you are showing, I am revising it verbally about pupillary light reflex pathway. When the light is falling on my retina, from the retina, you remember your pathway which I draw for you? Just I have drawn this. So from the two retinas, it crosses the chiasma, reaches the optic tract, and from the optic tract, pretectal, Eddinga-Westphal. This is your afferent. What is the efferent? Third nerve, inferior division of third nerve, nerve to inferior oblique, short ciliary nerve, ciliary ganglion, short ciliary nerves, iris sphincter. So know your pathway, just revise it. Now, it is the efferent pathway which is gone in case of Holmes-Addy pupil. Just remember this. So we are talking about the efferent pathway is gone in Holmes-Addy pupil or tonic pupil. Right? And what are the features? क्या पढ़ा हमने? Mainly it's generally a middle-aged female. One eye is mid-dilated. Right? There is a difference of pupil size in the two eyes. She is having problem of photophobia because of this mid-dilated. Affected eye is mid-dilated. Not everything can be written down. Some things you all should also write, beta. If I am writing, I am trying to write as much as possible. But if I am not writing, at least have the courtesy to work this much hard that you write. Hai na? If whatever you feel I have not written and you want to write, I hope that you are sitting with a copy and a pen and you can write it yourself as well. Okay. So that is the pupil is mid-dilated. Right. We come to what is the other abnormal pupillary reactions. This one is Marcus gun. What is Marcus gun? What are you looking at? I am showing the light into one eye and the other. One into other. What is that test called? Swinging flashlight test. Isn't it? Swinging flashlight test. Right? So what you see? Once the light is here, pupil constricts. But it is here, it's not constricting. When you again show it here, it constricts. Both the pupils are constricting. Here both are not constricting. No direct, no consensual. So this is mainly a feature of optic nerve lesion. It's the first sign of optic nerve disease. Right? So, and this is what is swinging flashlight test. This is how you diagnose relative afferent pupillary defect, which is also called Marcus gun pupil. Okay. What are you looking at here? I see ptosis. Is it okay now? I'm writing. So this is your ptosis. Then what else? Meiosis. Ptosis and meiosis. Horner's is best described by, this is the exam question. So Horner's is best described as ptosis or meiosis. So this is the case of Horner's. What else you get in Horner syndrome? You will get enophthalmos, loss of ciliospinal reflex. Most welcome. Okay? So Horner's, please remember the features: ptosis, meiosis, and of course you know it's an apparent enophthalmos. Actually the eye doesn't go inside. What else? Anhidrosis and loss of ciliospinal reflex. Ciliospinal reflex. Okay? Yeah. So please revise this. What is the question asked to you all? A patient is presenting with breathlessness and diagnosed with Pancoast tumor. Everybody please revise the sympathetic pathway. Sympathetic chain, see, this is here for you all. From the hypothalamus, midbrain, pons, medulla, where does it travel? It goes to ciliospinal center of Budge. Ciliospinal center of Budge कहाँ पे होता है? This is at C8, T1, T2. From there to apex of lung. So any patient with Pancoast tumor, it means going through the apex of lung. This is finally what will be affected? Sympathetic chain. So Horner's is what? Lesion of sympathetic chain. So what should be the answer here? Not a typical feature, it's asking. So exophthalmos, yes. Rest all is correct except what should be the actual answer? Enophthalmos. Correct option is enophthalmos, not exophthalmos. So this patient with Pancoast tumor, sympathetic chain lesion, presenting with Horner's, and therefore this you should answer. Is it clear? So please see how that sympathetic chain from the apex of the lung, it is going through superior cervical ganglion, and from there along the ICA, internal carotid artery, entering the cavernous sinuses, long ciliary, nasociliary, and supplying the dilator pupillae. So please revise your pathway. Everything is written here in this. Next is a patient 45 years presenting with difficulty in reacting to bright light. On examination, pupillary light reflex is absent but near reflex is preserved. Light reflex gone, near reflex present. We all know we are talking about Argyll Robertson pupil, which is also called light near dissociation. जिसमें क्या होता है? Accommodation reflex present. So, what is the cause of Argyll Robertson pupil? The lesion is in pretectal. No, the lesion should always be answered as pretectal nucleus. Okay? So, not Edinger-Westphal, we will say pretectal. Yeah. So, this is what is Argyll Robertson pupil or light near dissociation. This one is already done. I think by mistake it has been kept here. So anyway, you can revise it, that what is the trichromatic theory of the color vision? That blue is the short wavelength, medium is green, and long is red. So revise your color blindness. Next is optic nerve head changes in glaucoma are all except. We all know what are the optic nerve changes in glaucoma. CD ratio, cup disc ratio is more. There can be laminar dot sign, that is visible opening of lamina cribosa. होता है ना? So cup disc ratio changes will be there. Yes. What is bionetting? So that is bean pot appearance where the vessel will go and then it is not appearing after some time. That is double bending of vessel is bionetting. Nasal shifting of vessel I have showed you. But what is this? This is not even an optic nerve change. So this is the answer. Raynaud's nasal step is a visual field defect. It's a visual field defect. So simple question. Okay. Yeah. So if you look at the optic nerve changes and if you talk about CD ratio, what is the normal CD ratio? CD ratio normal is said to be less than equal to 0.3. But if I ask you when should you start suspecting glaucoma, I've told you start suspecting when it is more than 0.6 or above. Right? So more than 0.6 and above, right? So this is your cupping of disc. This is your glaucomatous cupping. One of the optic nerve head changes. What can be the other changes? Very quickly. So if this is the cup, we all know the periphery is the neuroretinal rim. Everything is given, so I'm not writing here. These are the main blood vessels. What was ISNT rule? What did we learn? If you talk about the width of the your rim, neurosensory retina, I mean to say neuroretinal rim, sorry. So the neuroretinal rim width is normal people, I is maximum, then S, then N, and then T. This is the width normally. But if that changes, that is breaking of ISNT rule. Okay, so this is what is called ISNT rule. Why will it break? Because the cupping always starts inferiorly. So suddenly you will see that inferior is not more. Here inferior was maximum. Inferior was maximum normally. Okay, so breaking of ISNT rule. What else? You just talked about bionetting. This is what it means. The vessel appears here, then you can't see it, and then it appears here. Bending at the two places. This is what is bionetting sign. Right? And look at here. This one is what is called nasal shifting of vessels. How the vessels first will shift and then it comes out. And these dotted, can you see these openings? This is what is called laminar dot sign. This is visible opening of lamina cribosa. The zenas, what you have to just understand is that any lesion of the sympathetic chain is supplying in the iris, it is supplying the dilator pupillae. The supply of dilator is gone, so there is meiosis. This is all you have to know. That is what you're learning, that in lesion of the sympathetic chain, there is meiosis. Nothing more. Okay? Yes. So these are, what were the optic nerve head changes we have just learned? Can we have patience to quickly revise it, please? CD ratio is more. Then ISNT rule is broken. Retinal rim is all thinning out. Bionetting sign. Laminar dot sign. Nasal shifting of vessels. Right? Okay. So when this question was asked, I thought we will revise this. Okay. And of course, you should know what are the different field effects in glaucoma. How it will first start as superonasal paracentral scotomas. Okay. So this is important, and then it joins the blind spot leading to sedal scotoma. So first it is paracentral, then sedal, then it becomes your arcuate, and on the both side this becomes double arcuate. Then everything is gone and only central and temporal field. That white part is the only place from where the patient can see. Now what I want you to be to the point. Don't go too much in detail if you don't want to. Just remember earliest field effect. If they ask you earliest visual field effect, you should answer paracentral scotoma in Jerem's area. Paracentral scotoma in Jerem's area. And if they ask you what is the field which island of vision is left behind, so last tak kaun sa island of vision is staying, you will answer temporal island of vision. Temporal island of vision. Okay? These two things are most important and you have to remember this. Yes. And sometimes what is bearing of blind spot? This is what it means, that there is a constriction of the isopter, but it is not involving the blind spot. The extent of the field. So what you understand what is constriction of isopter? Pay attention, I explain you. So if you am taking a field, and if the patient says, yes, I can see. So he is able to see when the object is here. Constriction means he is not able to see the object is here. When the object comes a little closer, now he is able to be aware that something is here. So uska isopter has constricted. You understood? So constriction of visual field. So this is what is called isopter contraction. Or we also call it, but you have to learn, I am giving you only the to the points here. Isopter contraction is also called bearing of blind spot. Okay. And what you have to know, that this is not the first visual field effect. It is not the first visual field effect. I am repeating because it's the commonest mistake. So please remember, we are not going to learn it as the first visual field defect. You can say it's a first visual field change, but whenever you are asked about first visual field defect, your answer will be yes, paracentral scotoma in the germs area. Then, of course, this we have to know. They can ask you in the exam, all of you. So, can you all tell me this? What type of tonometer? This is what is Schiod's. It's an indentation tonometer. Which is more reliable? Is it applanation or indentation? Schiod's is not that reliable because reading depends on the scleral rigidity of the patient. So, you will say this is not that reliable. What is this? Applanation. Which applanation? For self-measurement. I can just measure my own eye. So, this is called rebound. Yes, this is what is rebound. And what is this? This is your, when you go to the any IOPD, first of all, you will be made to sit either an autorefractometer and in front of this instrument. To have, though it is not an accurate method, it gives a very rough assessment, but this is what you will be asked to do. This is your pulse and a pulsar. Pulsar tonometer is what? Non-contact, where it is the puff of air which is applanating your cornea. Pulsar tonometer. If they ask you the question, it is non-contact. It is non-contact applanation tonometer. So if the question is self-measurement, you answer rebound, isn't it? And if the question is non-contact, you answer pulsar. What is this? This is the gold standard. That is Goldman. So in a Goldman, you put fluorescein dye. This is the instrument, and what you see are the two semicircles like this. We have to see that one end just touches the other end, inner side of the two semicircles. Okay. So one end just touches the other end. These are the two semicircles. Okay. So that was about your Goldman, right? It is the gold standard. Which is the okay, there's a question here for you all. Gold standard for measuring. You answer Goldman applanation tonometer. A small child is brought with complaints of photophobia and watering. This is a very important slide asked many times in all types of exams. We all should know this is a case of ophthalmos. Right? There is photophobia, watering. Tear passages are normal and clear but large cornea. So this is a case of congenital glaucoma. So we answer congenital glaucoma. In congenital glaucoma, this is another important question is treatment of choice of congenital glaucoma. So treatment of choice is this is a goniotome. You're passing from one limbus, you go to the other one and you're scraping it in this direction like this, right? To open the angle. What do you call this method? This is goniotomy. Okay, so treatment of choice, goniotomy. Then they can ask you what is this? This is your tono pen exam question. Tono pen is mainly the 2-3 points. One, it is the choice for children or infants. And we can use it in irregular scarred corneas. Irregular and scarred corneas. Aishwarya, we will try to wind it up by 40 minutes max. Okay, just keep focusing. And look at this one. What is this? This is our, can you see the tonometer here is over the lid, not on the cornea. We call it transpalpebral. So transpalpebral is mainly seen. Why will you try to do that? When there is keratoprosthesis, artificial cornea, then we can go for transpalpebral tonometer. And the name of this one is diaton. We call it diaton. Okay, what is this you're looking at is gonioscope. Gonioscopy mein you see the angle of anterior chamber. And please understand why I cannot see the angle on a slit lamp, because of total internal reflection. When I put a gonio lens, now there is no total internal reflection and I can see. If I am seeing through a reflected ray from a mirror, I call it indirect gonioscope. So, just remember, in gonioscopy or any procedure which I have to do in the angle, first important point, we don't need to dilate the pupil. No dilatation required, because I think it is very, very clear why. If this is your cornea, what is angle? Periphery between the cornea and the iris. So actually this is the angle, isn't it? This corresponding to the limbus inside, this is your angle structure you want to see. So if you dilate your pupil, it will all be obliterated. Your pupil should be constricted. Okay? And what is a gonio lens doing? It is increasing the refractive index so that there is no total internal reflection. No total internal reflection. Answer this question. A 50-year-old female presenting with acute painful red eye. Image is shown. What is the most likely diagnosis? All of you, acute painful red eye with a vertically, can you see the vertically oval dilated pupil? I can see congestion here. I can see corneal edema. And I can even see vertically oval dilated pupil. So what should I answer? Acute congestive glaucoma, right? So acute angle closure glaucoma. No, there is no term like stony pupil. It is a stony hard eye when it is absolute glaucoma, not in this stage, when the pressures are very high. Please correct yourself. The condition in the picture suggests a side effect of, yes, please revise your anti-glaucoma drugs and its side effects. Okay. So here what will you write? You're getting conjunctival deposits. This is your alpha agonist. So what should be your answer? Epinephrine, right? Adrenaline, epinephrine can lead to conjunctival deposits. Can you see this? We are talking about this one. Yes. Latanoprost, what does it do? It causes look here, this is what is heterochromia, difference of iris color. This is caused by latanoprost. Which eye have you given latanoprost here? In this eye. That is why it is darker in color. What else it can lead to? Hypertrichosis. More hairs. Hypertrichosis. And of course, what you see here is lid retraction. And lid retraction is mainly due to which drug? You will answer apraclonidine. Okay? Okay. So you will revise your anti-glaucoma drugs. What is the first line anti-glaucoma drug in adults? We should always answer PGF2 analogs. That is latanoprost for both open and closed angle. We will start with this. You should also know what is phacolytic glaucoma is the most common complication of. Phacolytic glaucoma occurs due to, if this is A, this is B, this is C and this is D. What should you answer? Yes, it is Morgagnian cataract. That is, it's a complication of Morgagnian cataract. Everybody remembers what is Morgagnian? Where leakage of lens, hypermature cataract, slowly there is leakage of lens protein and it is blocking the trabecular meshwork, right, leading to phacolytic glaucoma. Okay. Which lenticular opacity diminishes the vision most? Do we have that picture here? No, we don't. It is this one. Posterior subcapsular cataract. This is what is posterior subcapsular. So posterior subcapsular is also called cupuliform cataract. We call it posterior subcapsular cataract is also called cupuliform cataract. Right? Okay, we come to the next. You have a patient chronically on corticosteroids. So, diagnose a complicated cataract. What is this type of cataract called? We all know. Again, this is posterior sub. So, can you see this? Section दिख रहा है, ये तो cornea का section हो गया. This is cornea. This one is cornea. Here the lens, everything is clear here in the lens. But this is all affected. This is your posterior subcapsular. Right? So, do we all remember this? Please revise with me. About BSC causes PSC. Toxic cataract, what did you learn? That what are the drugs which can lead to PSC? Busulfan. Then steroids, S for steroids, and chloroquine. It will lead to posterior subcapsular cataracts. And rest all others. What are the all others? Long-acting miotics. We have to talk about, if I am talking about toxic cataract, I am writing here as well. So, I just said BSC causes PSC. So, what are the, this I have just explained. Then what are the rest? Like long-acting miotics. Ecothiopate, phospholine iodide. Long-acting miotics. What else? Tell me. Amiodarone. Gold. All these will cause what? Anterior subcapsular cataract. Yes, very good. Chalo, we come to the next slide. So all of you, what is this? Let's see this. I can see posterior conical protrusion. Why I say posterior? Because this is the cornea. So this is your posterior lenticonus. Posterior lenticonus. So you have one question, where do you see it? Loess syndrome, isn't it? That is oculocerebrorenal syndrome. Then we have anterior lenticonus here. Can you see this? Look here. How the anterior part of the lens is conical now here. So this is your anterior lenticonus. And we know anterior lenticonus is seen in two conditions you should know. Alport syndrome and what else? Waardenburg syndrome. Waardenburg syndrome. Very good. Alports you all should know is familial hemorrhagic nephritis. And what else you get in case of anterior lenticonus? Again, important point is this one, which is called oil globule reflex. It's not droplet, okay? This is oil globule reflex, which is a feature of your anterior lenticonus. Then what is this? We come to other oils also. There are three oils you learn. What are the three oils? One is globule reflex. Second is oil droplet cataract. This is your oil droplet cataract. And oil droplet cataract, where do you see? We all know galactosemia. It can be a reversible cataract. Which vitamin deficiency? Which enzyme deficiency? I'm so sorry. It is G-put deficiency. Galactose phosphoruridyl transferase. Right. And then we talk about this one. Third oil. What is that third oil? Oil droplet reflex. Oil droplet reflex. And oil droplet reflex is again looks same only. It is seen in keratoconus. How do you see it is important, guys. You have to know by distant direct ophthalmoscopy. Distant direct ophthalmoscopy. We come to the next question here. 70-year-old patient who was using presbyopic glasses. near glasses. For past few years now able to comfortably read the newspaper without the glasses. What is the most likely diagnosis? See, the framing of the question I'm not totally agreeing with, because you can have some lessening of number which you call as improvement of near glass. Very rarely you will see the patient is not needing any glass. Okay. But anyway, either ways, what are we talking about? Second sight of old age, isn't it? And why do you get that second sight, and why is there improvement? So what you are seeing here is improvement of near glass. And this improvement of near glass ka matlab, the number of the near glass is lesser now. I need lesser number. This is what is called second sight. Very nice. All of you are answering very well. It is called second sight of old age. And this is what is due to, what is the story? I think I every time tell you, the patient has started developing nuclear sclerosis. Hardening of nucleus is causing more refractive index. Power is increased, so he needs lesser number on his reading glasses. The power is increased means more power, it is means myopia. So it goes towards myopia. There is a myopic shift. When it is power is getting more and more, it is a myopic shift. When power gets lesser, it is called hypermetropic shift. So here, due to refractive index, this is happening. Hence, we call it index myopia. Correct, all of you? So, due to this index myopia, this patient will not need or need the glasses, or there will be improvement in his near glass. Correct? So, answer is nuclear cataract. It happens due to nuclear sclerosis or nuclear cataract. Very good. Okay, we come to the next. What is this you're looking at? Polychromatic multiple colors. Yes, this is complicated cataract. Means any anterior segment or posterior segment disease, either anterior segment disease or a posterior segment disease, is leading to cataract. This is called complicated. Questions: polychromatic luster, blood clump appearance. These are the two things which are asked in the exam. Most common type of complicated is always, most commonly it is a posterior subcapsular to start with. Okay. Next question. Constantly changing refractive error is seen in. So, changing refractive error, all of you. What will you answer? I want the answer first before I comment on this. What will be your answer? Constantly changing. Very good. So we should not answer diabetic cataract. Okay, answer is Morganian. What are the causes of constantly changing? We learn like this in my style: early cataract, late glaucoma, and diabetes. Okay, not diabetic cataract, but diabetes per se. The disease per se can lead to this. How? If there is more sugar in hyperglycemia, what happens? There is myopic, more swelling of the lens, myopic shift. In hypoglycemia, less swelling of the lens, okay, I should write, let me see. Now you can see, in hypoglycemia, it is vice versa, that is hypermetropic shift. So that is one. And early cataract, it's mainly Morganian, because as the water content keeps increasing or decreasing, the power will keep changing. Okay, what are we looking at? If I want you all to give one heading, this looks like congenital cataract. Okay, so this one is your lamellar cataract, where single lamella is involved. And in a lamellar cataract, these additional opacities that you see here like this are called riders. Another question they ask you, it occurs due to vitamin D deficiency. It is the most common congenital causing marked diminution of vision, then it is this one. And then comes your blue dot cataract. Blue dot cataract is mainly a feature, is most common congenital. It doesn't diminish the vision so much, but most common congenital cataract, we answer blue dot. And most common congenital causing diminution of vision is lamellar. And with what is this one? This is pre-senile myotonic dystrophy. We call it Christmas tree cataract. It is Christmas tree cataract. Right? Yeah. Myotonic. Another pre-senile is in front of you. What is this? This is in atopic dermatitis. We call it shield cataract. It is a feature of atopic dermatitis. Why do you say, when do you say it as pre-senile matlab? Before old age, before 50 years. A 68-year-old female had a diabetic cataract for past 3 months. Accumulation of which of the following substances is responsible? We all know it is sorbitol and fructose. So sorbitol accumulation, sorbitol is very hyperosmotic, it will imbibe water. We all know this. Okay. We next talk about this slide. What is the step? They have asked you like this. So what are you seeing here? You're holding the capsule and trying to tear it like this. You are looking at CCC. What is CCC? Continuous curvilinear capsulorhexis. And this is also an exam slide. What is happening? I can see a clean capsulorhexis here and I can see lens fragmentation here. So what surgery are we doing? This is your femtolaser cataract surgery. Assisted cataract surgery. Femtolaser assisted cataract surgery. And of course here what you are looking at is phacoemulsification, the animated picture of phaco. What is the question asked here for phaco? Is incision length. We will remember it as 2.75 to 3.25 mm. पौने 3 से सवा 3. 2.75 mm to 3.25 mm. The next question is, Ria was found to have a height of more than 95 percentile for her age. I think you all know, answer is already given. So if you look at the whole details, I think you have solved this question. Flat feet, mild scoliosis, slender and long fingers. We are talking about Marfan syndrome. And therefore, of course, it is subluxation. And what is the direction of subluxation in Marfan's? How do we learn that in my style? Make an M of Marfan's and put an arrow here. So, what type? This is called superotemporal ectopia lentis. So, most commonly in Marfan's, what you see is superotemporal. And then you can make a dotted line here and here. And then you are going to write here H. So, just the opposite in homocystinuria. What you see is inferonasal. In homocystinuria, it is inferonasal. We come to next question. An acute infectious endophthalmitis after cataract surgery, all except acute endophthalmitis, infectious, staph epidermidis. You should know this. So, most common is this? Yes. Okay, is usually associated with decreased visual acuity. Of course, marked diminution of vision, fundus glow hi chala jata hai. Associated with hypopyon, edematous slit, but it has to be painful, not painless. So, it's a simple question. Answer is B. Okay? Yeah. So, this is a case of endophthalmitis. We can see some edema here. We can see the hypopyon. And when we will try to see the fundus, there will be no fundus glow. There's one more question I would like to mention. What is the treatment of endophthalmitis? If this patient has less than hand movement vision, we go for pars plana vitrectomy. Hand movement or above. Now we have to go for intravitreal antibiotic injections. In intravitreal antibiotics, what we have to remember, gentamicin and amikacin are contraindicated. Okay. So I'm writing for some gentamicin and amikacin are contraindicated. Remember that. Most common long-term complication of cataract surgery is this one. What do you call it? Posterior capsular opacification. We also call it after cataract. Isn't it? What is the treatment of choice? NDR, posterior capsulotomy. Right? Okay. Acute infectious, I think this is repeated, sorry. This is done. We come to this one. 3 months following cataract surgery, patient comes with complaints of decreased visual acuity. On examination after cataract, yes, answer is NDR. What do you do with NDR? What we are doing is, we are just, if this is your posterior capsule, we just make a, if suppose this was all hazy posterior capsule, you are making us, cutting the posterior capsule at the center and making an opening like this, right? So this is your posterior capsulotomy by NDR. Yeah. Right. What is this now? What are these instruments? This is a tonometer. No, please don't make a mistake. I can see a fiber, just a little hair-like extension. This is your aesthesiometer to see the corneal sensation. What is this? Pachymeter. What is pachymeter for? We all know thickness of cornea. And what is this one? This is your specular microscopy. Specular microscopy किसके लिए होती है? To examine the endothelial cells. So these are the endothelial cells. Do you remember the lecture we had discussed? Polymorphism, pleomorphism, ये सारी चीज़ें we can see through this. And what is this investigation? This is what is called, we are doing the corneal topography to find the curvature of the cornea. The glycosaminoglycan, this is a recent question of exam, present in the cornea responsible for transparency. You should answer what? Keratin sulfate. So if you talk about, in my style, what are the factors? This is the cornea. Okay. This is your epithelial layer. Right. This is your Bowman's membrane. This is the stroma. Of course, there is this Duas layer. Then comes your Descemet's membrane. And this is your endothelium. Let's make this as the Duas layer. Now what you have to know, Duas layer is the strongest layer just between Descemet's and stroma. This much is enough. It's the 6th layer of the cornea. Coming to what are the factors to maintain the transparency. How can you maintain the transparency of the cornea? So layer wise if you learn, you will not forget. Number 1 is regular arrangement of epithelium. No mitotic clumping. Second, regular arrangement of stromal lamella. It is said that the distance between the two stromal lamella is less than half the wavelength of light. Less than half the wavelength of light. So, the thing is, how does it maintain that spacing? That spacing is maintained by glycosaminoglycans in the stroma. Primarily, it is keratin sulfate. And one more that you have to know is chondroitin sulfate. Keratin and chondroitin sulfate. But if keratin is given, we answer this. Next factor, of course, we know endothelial cells. It is the sodium potassium ATPase pump which keeps pumping the water back into the aqueous. So endothelial is very important. Okay? So dehydrated state is maintained by endothelial sodium potassium ATPase pump. Right? Any other factor to maintain transparency? One is epithelium, second is stroma, third is endothelium. Fourth will be normal intraocular pressure. If it is more than basic cranial stromal pressure, again there can be IOP, there can be edema. Edema should not have happened, isn't it? We are trying to maintain the transparency. And of course, we will not forget avascularity of the cornea. Very good. Avascular cornea. Okay? Yes, fit Madibone. That's very nice. So these are the factors to maintain transparency. Now what are you looking at? So this one I see hyphae are extending, dry rough. This is keratomycosis. What is the most common fungus causing keratomycosis? Most common is Aspergillus fumigatus. Don't forget. What else you have to know is repeated. Of course, we should know this, that apart from this, second important thing to remember is unsterile hypopion. Third question is satellite nodules. These are all questions on keratomycosis. And of course, drug of choice is natamycin. So some important points regarding keratomycosis. Drug of choice, natamycin. What is this? This is a bacterial corneal ulcer. And in bacterial keratitis, we will not forget what? That it is sterile hypopion. And symptoms are much more than the signs compared to fungus. Fungus में signs are more. ठीक है? Yeah. What do you look here at? Are superficial punctate keratitis of viral infection. And they will ask you about this is an important thing, that in which case is not fixed? Not fixed in bacterial. Yes. Yes, it is not fixed in bacterial. Okay. VYBHVV. How should I pronounce that? Okay. Yes. So this is a herpes simplex. And why do you say it's a dendritic ulcer? Please understand why it is a dendritic ulcer. Because it has knobbed ends. Ends are knobbed. So this is HSV. It is not a feature of zoster. Please remember. Later it can lead to geographical ulcer. This is the geographical ulcer. And here I don't see knobbed ends. This is what is pseudodendrites, which are the feature of herpes zoster ophthalmicus. Okay? All of you, they have asked you what is Hutchinson's rule. You remember that? What is Hutchinson's rule? If the tip of the nose is involved, eye will be involved. So this is what is. Please revise your Hutchinson's rule. It is due to involvement of nasociliary nerve. Nasociliary nerve. So there's a question. Patient is presenting with painless ulcer, long branching. Actually, it should not be painless. It's a wrong framing. Of course, there is a decreased corneal sensation in viral keratitis. If I ask you what is the pathognomic feature of viral keratitis, it is decreased corneal sensation. But still it is not painless. So I don't agree with this painless term here. But yes, long branching ulcer, this was this year's question only. And the answer is dendritic. Anything long branching with reduced corneal sensation, we are talking about dendritic ulcers. Okay. So if this is a dendritic ulcer, it has to be herpes simplex. Yes. Yes. Our 18-year-old boy is presenting with history of injury, which is caused by climbing, during climbing. So you all know that in a keratomycosis, injury by vegetative matter or organic matter is the most common cause for any keratomycosis. There is pain, photophobia, right? And the slit lamp is showing this. So this one will be unsterile hypopion, isn't it? So we are talking about which among the following is a feature of this condition? So we answer satellite nodules, right? Ring abscess किसमें मिलता है? Acanthamoeba. Dendritic ulcer, herpes simplex. And what is reverse hypopion? In retinal detachment treatment, you are putting silicone oil in the vitreous. Sometimes it leaks, goes into the anterior chamber and floats over the aqueous. That is called reverse hypopion or hyperleon. So we will answer here satellite lesions. 45-year-old presenting with, this is all your question. I'm quickly taking it. You all know these are the lesions and the distribution of the trigeminal. We are talking about herpes zoster ophthalmicus. This is the ring lesion which can become the ring abscess of Acanthamoeba keratitis. Please don't forget that it will be mainly due to wearing of contact lenses and washing the lenses with tap water. wearing the contact lens, swimming like this without wearing your goggles. Okay, but it's a rare infection. But most common infection after contact lens use, if something is asked like this, most common infection after contact lens use, now you will answer is Pseudomonas. They have also asked you about culture media of Acanthamoeba is non-nutrient agar with E. coli. Don't forget, it is non-nutrient agar with E. coli. What next are you seeing? This is salmon patch of interstitial keratitis. And where do you get it? It is mainly a feature of syphilitic infection, syphilis. Yes, very good, Shivangi. Answer this one. All are true regarding the condition in the figure below except. So what are you seeing in the figure first of all? I can see thinning of the sclera, exposed uveal tissue. This condition is scleromalacia perforans, which is leading to ciliary staphyloma. Some ectasia leading to ciliary staphyloma. So actually it is scleromalacia perforans, and this can lead to later as causing, it is complicating as ciliary staphyloma. Got it? So अब आप इसमें क्या बोलोगे? It is common in females, it is a ciliary staphyloma, it is common in rheumatoid arthritis, it causes perforation. This is correct, this is correct, this is correct. It's mainly seen in patients of rheumatoid arthritis, but it will not cause perforation. It looks like that it can perforate anytime, but it doesn't. Got it? So perforation will only happen, there can be one condition, if intraocular pressure is raised. Otherwise not. Okay. Next question is 35-year-old male is presenting with, can you see, ulcer ke liye he was treated and with antibiotics, remarkable finding. I think why I can find it here, this is anterior staphyloma. It's very, very diagnostic. Most common cause of anterior staphyloma, I hope you all know, is pseudocornea. What is pseudocornea? When the whole corneal tissue is replaced by inflammatory exudate due to infection by very virulent organism. अब वो cornea actual है ही नहीं. So here we are, types of staphyloma, very simple, anterior, through the limbus intercalary, ciliary body ciliary, equatorial, posterior. Got it? Yeah. Which is the most common? We have just learned is posterior. Where do you get posterior? Pathological myopia. We learned it? Yeah. Ciliary, it is mainly scleritis. Anterior, I just said pseudocornea. Intercalary, learn with me, peripheral corneal ulcer. Equatorial, again learn as scleritis. So now you have completed the whole chapter on staphyloma. Okay? Yeah. What are you looking at? Very commonly asked question. I hope this is easy and you all know this. What is this? Is KF ring. Right? KF ring, what are the points to remember? It is copper deposition in Descemet's membrane. Feature of Wilson's disease. Enough. And what is case of Fleischer ke alawa? What is Fleischer's ring? This is Fleischer's ring, where it is this type of deposition which is seen on keratoconus. So here this patient is a case of keratoconus and it's an iron deposition. So iron deposition in patients of keratoconus at the base of the cone. This iron deposition is what is called Fleischer's ring. Okay, so you have one question here. True association include all except. What will you answer? All except. Myotonic में pre-senile होता है, हाँ, Christmas tree, so this is a yes. Gold, we just learned, anterior subcapsular, Loeys syndrome, posterior. Wilson's disease, this is Kayser-Fleischer ring. Yeah, very good. Keratoconus. V-shaped deformity on the lower lid. On looking down, what do you call this? Munson's sign. Isn't it? And we have already talked about oil droplet reflex seen in keratoconus. क्या पढ़ाया था? It is seen mainly in distant direct ophthalmoscopy. Which is not seen in keratoconus. Munson sign, it is seen. Scissor reflex, yes, that is seen. Where do you see scissors reflex? When you do retinoscopy. So in patients with keratoconus on retinoscopy. Is it irregular astigmatism? Yes, this I just mentioned at the start of our session. It is irregular. What is wrong is yes. This is the answer. Why? What do you get here? Vogue stria, not half stria. V for V, vogue parallel to the steeper axis. We get vogue stria. Both are break in Descemet's membrane, but half stria is more circular. I think I have the figure. I have this slide. Yes. See, this is your half stria. Right? Where do you see half stria? Congenital glaucoma or ophthalmos. And vogue stria, this one is in keratoconus. Okay? Again, this is the same vogue stria. Do you see one more feature we have learnt along in keratoconus is prominent nerves. These are the prominent nerves. Why do you get a prominent corneal nerves? Due to thinning of the cornea. Here there is no thickening of nerves. It's the thinning of cornea due to ectasia. So these are prominent corneal nerves. It is due to thinning of the cornea. Okay, we come to the next one. What is the refractive error seen in the condition? I think we are very clear it is myopia with irregular astigmatism. So many times done. Now a 26-year-old patient is complaining of blurred vision, photophobia, pain, congestion and joint pains. Ocular complaints are unilateral. So any joint pain with all the features of anterior uveitis, we are talking about HLA-B27, isn't it? And what are those arthritis? Do you remember the arthritis associated uveitis? It can be JRA, it can be ankylosing spondylitis, it can be psoriatic arthritis. And one more that you have to revise is Retter's syndrome. Retter's syndrome. Okay. Next question is patient with sarcoidosis with Cope's nodule on ophthalmology. What are these? Where are the Cope's nodule? Very simple question again of your exam. Cope's is at the pupillary border or is it at the base? It is at the pupillary border. So these are Cope's. These are at the pupillary border. Where do you get nodules? Cope's you can get in both. Remember this, the Cope's you can get both in granulomatous as well as non-granulomatous uveitis. In both the features you can get Cope's. But when you talk about Basaka nodule, this is mainly in base of B for B, B for B, base of the iris. Basaka is seen in only granulomatous uveitis. Okay. Let's see one by one. What is this? I can see a small disc and fovea. That means I'm mainly looking through indirect ophthalmoscopy. I can see this deposition here. This is your snow banking, which is pathognomic feature of intermediate uveitis. Intermediate uveitis. Then of course we have already talked about candle wax drippings. And candle wax drippings is seen in sarcoidosis. Next we have talked about, can you see this? I can see it very hazy. This is your headlight in fog appearance. Where do you see headlight in fog? We see it in toxoplasmosis. So we will remember all this, please revise it. And can you see this salt and pepper fundus seen in rubella, syphilis? So this is what is diffuse chorioretinitis. We also call it salt and pepper fundus. Right? Yeah. Coming to this one. What do you see in this patient? This whole thing, whole slide is one diagnosis. I can see heterochromia iridis. And the affected eye, in latanoprost, it was darker eye where you were putting the drug. In this case, uveitis is seen in the lighter color eye. That is why you are seeing in this. And you can also see the cataract due to this complication here. Can we make out the cataract? So actually this is heterochromia iridis, and this is the eye with uveitis. We are talking about Fuchs heterochromic cyclitis. Yes, Fuchs heterochromic cyclitis. And what is the next feature? Stellate capes. Look at this. These are stellate capes. So this is what is called stellate capes. What else you get? We get iris atrophy. Can you see this? Iris atrophy, and this is the reason there is no posterior synechia. And when you're doing a paracentesis, you can get a bleeding like this, which is called Amsler's sign. So this is what is Amsler's sign. Yes, so we have to know these are all features of Fuchs heterochromic cyclitis. Right? Okay. Come on, not answer this one. So you have this and this. Multiple cotton wool spots. This is your HIV microangiopathy. Isn't it? You have learned that most common presentation of ocular feature of HIV is microangiopathy. And generally, prominently, what we get is cotton wool spots. Right? And what do you see here? This is your necrosis. This one is necrosis. And this is your hemorrhage. So this is what is sauce and cheese retinopathy. Where do you see sauce and cheese retinopathy? It is mainly a feature of CMV retinitis. CMV retinitis is most common opportunist infection. Most common opportunist infection. Okay, then coming to sympathetic ophthalmitis, everybody knows perforating injury in one eye is causing uveitis in the other eye. And that uveitis of that other eye is what is called sympathetic ophthalmitis, isn't it? So, let's see all except, which is the wrong statement. We have to find which one is the wrong statement. Occurs after perforating injury? Yes. Is it type 4? Yes. First symptom is photophobia. Is it a granulomatous non-suppurative? Yes. First symptom is not photophobia. Why? Because first sign क्या होता है? It is starting from behind the lens, retrolental flare. If the first sign is retrolental flare, means the problem is in the ciliary body area. So if the first sign retrolental flare hai, so what will be the first symptom? You should answer difficulty in near vision. Main function of ciliary muscle is accommodation. So first symptom will be decreased near vision or decreased accommodation. Okay? Yeah. The procedure you can diagnose all except. This procedure can diagnose all except. So, think yourself, we are looking at syringing. And this can diagnose all except functional obstructions. Isn't it? So, we should answer here functional obstruction. Do you understand the basic? Let me draw it for you to make you clear. Very simple basis. Look here. So, this is your eye. This is lower puncta, upper canaliculi, lower canaliculi. This is upper canaliculi, lower canaliculi, going into the common canaliculi. It's a simplified diagram. Going into the lacrimal sac. And this is your nasolacrimal duct. And this NLD opens where? This is first question. We all know it's inferior meatus anteriorly. Both the things are asked. Okay? It is opening inferior meatus anteriorly. Now, you have to find out. So, what you are doing? You are injecting water here, right? If there is any blockage at common canaliculi level or in the NLD level, whatever water you are injecting will regurgitate from the upper puncta. So, I know that these are the level. If there is any, you are injecting the water and because the blockage is at the canalicular level, the water will come out from the same puncta. So, if there is regurgitation from the same puncta, it is a canalicular block. And if it is coming out from the upper puncta, it can either be common canalicular or NLD block. Right? Yes, it's all medially. Aishwarya. ठीक है? So, all of you, what were we discussing? That it can canalicular, common canalicular, NLD, everything can be done, but this cannot be done. How do you generally see the functional obstructions? How do you confirm? We confirm it with either, this is the best way to confirm, that is decrioscintilography. So if they ask you what is the choice of investigation to see the functional blockage, the investigation of choices, go label the tear with the radioactive dye and see the flow of the tear in a physiological condition through the gamma counter. It will tell you, right? Another method, it is Jones dye test. Just revise the Jones dye test. A very quick thing here. Test 1 negative, test 2 negative. It is a functional blockage. If 1 and 2 both are negative, it is a functional blockage. Right? Okay. What is this instrument in which the following surgeries are done? Abhi baat hui thi, this is what is bone punch, isn't it? So answer is decriocystorhinostomy, because this is your bone punch. Mother is noticing a mucopurulent discharge from the right puncta of her child and a history of increasing watering. 3 months old child. It has to be Krigler's massage, isn't it? This massage is called Krigler's massage. You can try this Krigler's massage till what time, all of you? Till 9 months. Till 9 months. I can try this. And after, from 9 months onwards, I can go for probing. If more than 9 months, I can opt probing. But the patient should be more than 4 years if I have to opt for DCR. Right? Yeah. Okay, what are you looking at here? This is Hertel's exophthalmometer. And Hertel's exophthalmometer is mainly used to see the proptosis. We are measuring proptosis. Then you have got a question something like this. If you look at this patient, so this patient, 20-year-old male, presenting to the OPD with complaints of fever, left lid swelling for the past 2 days. He had mild flu-like features and illness a week ago, but no history of trauma. There is chemosis, conjunctival edema, and protrusion. There is no chemosis and no protrusion of the eyeball. Had there be any inflammation in the orbit, there has to be protrusion of the eyeball, isn't it? So no chemosis, no protrusion. Definitely this is a case of inflammation in front of the orbital septum. इसको क्या बोलोगे? Pre-septal cellulitis. Now all of you, let me explain you in my simple way. ये तुम्हारा bony orbit है, ये lid है, tarsal plate, wherever posteriorly it is ending. So this is the bony orbit, ठीक है ना? And this is your tarsal plate. This tarsal plate is ending posteriorly here. ठीक? This is the tarsal plate with the where it is posteriorly ending. Now the gap here is filled by a thin connective tissue, and this is what is orbital septum. The same is in the lower lid. If I make a lower lid, I'll make this is the inferior bony margin. I make this is your another lower tarsal plate, and this space is again filled with orbital septum. Sorry, to thoda sa different ho gaya. It's closer, but it means this one. Okay, and of course this is your eye here. Now you got it. So any inflammation in front of the septum, I'm not worried. This is what is called. So any orbital septum K, if there is inflammation in the front, we call it preseptal cellulitis. Okay? And if the inflammation is behind, now you call it orbital cellulitis. Clear okay concept? So here in case if there is behind, definitely there has to be some proptosis. But here there is not, so we answer preseptal. And of course this diagram has to be very, very clear that if this is the pituitary gland, what is the relation, where is the chiasma, and these are the two cavernous sinuses. What are the nerves which are passing through the wall of the sinus? Are these, and the body is the sixth nerve. Therefore, if it was an orbital cellulitis, then orbital cellulitis is an emergency because of risk of involving cavernous sinuses, cavernous sinus thrombosis का first sign आपसे पूछता है, you have to answer sixth nerve palsy. It is sixth nerve palsy. Okay, a patient is presenting with proptosis and that increases when bending down. So, head posture say the amount of proptosis is differing. What type of proptosis you call? Intermittent proptosis. What is the main cause of intermittent proptosis? We will answer orbital varices. No, why are you answering C? Increases on bending down. What is the? Yes. So we have to answer this. Look at these CT scans. In this one, I can see that the belly of the muscle is involved, but this only belly is involved. This tendon is all spared. Can you see that? Appreciate that? This is typical of thyroid eye disease. It's a thyroid myopathy where, which is the first muscle to be involved in thyroid myopathy? What have you learned? Inferior rectus. What part of muscle is involved? The belly. What do you see in the second? Fusiform enlargement of the optic nerve. Fusiform enlargement of optic nerve. The answer will be due to optic nerve gliomas. So revise this please. These are optic nerve glioma. Third one, what I am seeing? I see tubular enlargement with calcification. This is the calcification. So, tubular enlargement with calcification. Now you will answer as, where do you get it? Meningiomas. Now you answer meningiomas. Right? Okay, look at this one. If I have to ask you to give one heading to this slide, I will wait for this answer, all of you. What will you answer? Batao. I want you to give the heading to this slide. What will you answer? 3, 2, 1. Be more specific. Rahul? Which trauma? Yes, Devi. It is blunt trauma or concussion injury. So, this is what is concussion injury or blunt trauma. Very good. What are the features? What do you see here? Imprint of iris pigment on the, what is this? Anterior capsule. It is asked in the exam. Anterior capsule of lens. This is what is called Vossius ring. What next feature you are seeing? Irido disinsertion of iris from its root. Iridodialysis. And because of iridodialysis, another exam question here. Shape of the pupil. It is D-shaped pupil. So this becomes a D-shaped pupil. Okay, then what is the third? You all know we are looking at teardrop sign, which is a feature of blowout fracture. What is blowout fracture? Fracture floor of orbit. Blowout fracture, that is fracture floor of orbit. Okay, chalo, next one. Do we get any other thing in blunt trauma? Yes. What is this? This is your rosette shaped cataract. This is again a feature of blunt trauma. Another question starts from posterior cortex. Starts from posterior cortex. But is this also rosette shaped? No, this is called sunflower cataract. So where do you see sunflower? Sunflower cataract is a feature of calcosis, which is, you all know what is this. It's a copper in the eye. KF ring, sunflower cataract. These are the two features. Okay, this is a patient, a CT revealing the following findings after blunt trauma to the eye. What is the diagnosis? So I think this was this year's recent FMGE question. Teardrop sign can be seen here, and therefore the answer would be blowout fracture, that is B. Yes. So patient is presenting to you with pain, redness in the right eye following injury during welding. Right? Image is seen below. Look at the image. I can see an iron particle all here. This is the foreign body here. In that case, what I do, under the slit lamp, I will put 1 drop of xylocaine with 26 gauge needle. I of course have to check the depth of the foreign body in the cornea. Is it too deep or is it superficial? If it is safe, I will just remove it and pad and bandage with antibiotic ointment. The next day, patient is absolutely fine. So answer is removal by 26 gauge. This is also your PYQ. Very good, Preeti. That is for intraocular foreign body. Any intraocular foreign body can be RN containing generally. So therefore, we avoid doing MRI. The choice of treatment for intraocular foreign body, choice of investigation for intraocular foreign body would be CT scan and not MRI. Very nice. Okay. And what do you look at? Another feature of blunt trauma. We all know what is this. This is called hyphema. What are the two main problems with this hyphema? One, it can lead to glaucoma, and another, it can lead to permanent corneal staining. Right? Okay. We come to the next. Patient is hit by a tennis ball and is developing this hyphema. Tell me the source of the bleeding. So, all of you, don't forget what I taught you earlier also. Very simple. If this is the orbit, this is the eyeball, and I'm showing you the uveal tissue, iris, ciliary, body and choroid here. And this dotted line is the retina. I am just showing you these. Main supply is ophthalmic. Ophthalmic ki one branch which is going to the uveal tissue are ciliary. Ciliary can be anterior ciliary, which are muscular branches, and posterior ciliary can be short posterior ciliary or long, one from here, one from here. Should I repeat? I said ophthalmic artery, quick revision here, ophthalmic artery, ciliary branches and one branch central retinal artery to the retina. Ciliary में anterior and posterior ciliary. Anterior ciliary are muscular. Posterior ciliary क्या पड़ा? Short and long. Short are many in number. This is supplying the choroid and outer four layer of retina. And what is the long supplying? Going anteriorly at the base of the iris here. It will make an anastomosis with anterior ciliary. This anastomosis with anterior ciliary is called major arterial circle. Why do you call it a circle? देखो ये iris है. ये iris है. If this is the iris and this is the pupillary border. Now I am saying one major आपका जो anastomosis है which is at the base of the iris like a circle. Okay. So this is the circle. Now from this major arterial circle, small branches will come to pupillary border and form minor arterial circle. So from this major pupillary border, this forms a minor arteries. Got it, all of you? Main source of bleeding will be base of iris. वहीं पे trauma, blunt trauma में, think with me, iridodylisis is happening, blood vessels are getting punctured there, leading to hyphema and bleeding. So what will be your answer here? I will answer circularis arteriosus major. Major arterial circle is called this. And what is minor arterial circle known as? Circulus arteriosus minor. So you will answer major. And of course, if I want to complete this whole information for you, the separate branch central retinal artery is supplying the inner 6 layers of the retina. So I've just made things very quickly easy for you, hope so. Right? Okay. Next question. Industrial worker was admitted to hospital for eye injury sustained while cutting. I think this is what Preeti you were talking about. Chisel and hammer is the most common cause for any this metal intraocular foreign body. Best investigation. So never answer MRI. You will answer CT scan. Right? So this is done. Okay. A patient is presenting with recurrent chalazion. What is a chalazion? What will you answer? What is a chalazion? You will say it is lipogranulomatous inflammation of lacrimal gland. Isn't it? Lacrimal gland. So all of you, so What did I say? Lacrimal gland. I'm so sorry. I think I'm also tired now. Libroglandiomatous inflammation of meibomian gland. Please correct this. Of meibomian glands. So sorry. Please correct this. Of meibomian glands. है ना? And very simply I teach like this. Any recurrent. So meibomian gland कौन सा gland होता है? Sebaceous gland. So because it's a sebaceous gland, what do you do? I will get recurrent means I should check for sebaceous cell carcinoma. I should check for sebaceous cell carcinoma. Isn't it? Okay, so these are the two questions. Can you tell me most common cause of recurrent chalazion? If I don't want to think about carcinomas. Uncorrected mild refractive error. You have a very small number in the eye. You don't want to wear specs. So your image is not clear on the retina, which you don't want to accept. Every time you want to clear your image, you rub your eyes. You rub your eyes so frequently that it gets inflamed again and again and again. That is uncorrected mild refractive error becomes one of the most common cause of this recurrent chalazion. ठीक है? Uncorrected. Again, I'll be told to write, so I'm writing uncorrected mild refractive error. Is that clear? Happy? For most common cause of recurrent chalazion. Okay? Okay. So, now if there is a painful swelling, it's an acute inflammation of meibomian glands. And acute inflammation of meibomian glands. What do you call this one? This is called hordeolum. Hordeolum matlab swelling internum on the tarsal plate. And the same painful swelling on the lid margin is called hordeolum externum. And this is also called stye. Okay. So if you make a diagram here from which I will just make it for you. This is the tarsal plate, lid margin. This is the gray line and these are the lashes. So very simple, in one diagram we can understand everything. Kaise? Painful swelling on the meibomium is hordeolum internum. Painful swelling at the lid margin is stye. And painless ideally it should be in green. So painless swelling here, this is your chalazion. Okay? So now you shouldn't be getting confused. So it's important, ask in the exam frequently. Here we go. Mother brought her 11-month-old kid to you for an eye examination, and what she noticed is that his left upper lid went up and down. Her hoga na, when she used to breastfeed, she was told by the pediatrician that the baby had left eye ptosis. So the eyelid is up and down with the jaw movement. Obviously, we are talking about Marcus gun, jaw winking phenomenon. What happens here? See in this child. Ptosis hai. The moment the jaw is open, ptosis is, the lid goes up. With the movement of the jaw. Jaw movement, lid goes up. So what is happening? Abnormal connection between levator palpebrae superioris and lateral pterygoid muscle. Lateral pterygoid muscle. Right? That means LPS is third nerve. This is fifth nerve. Okay? Aberrant connection between, very good. The aberrant connection is between third and the fifth. Nice, Preeti, very nice. A patient is presenting with eyelid crusting and a gritty sensation between the lids. Eyelid crusting, gritty sensation. I think we are talking about this. So it is an ulcerative blepharitis. And when there are dandruffs, we all know it is squamous. So this is also your exam question. So what will you answer here? It's a chronic blepharitis. It's a chronic blepharitis. Okay, a few more conditions here for you all. So all of you, what do you see here? Pay attention. What is this? Extra row of eyelashes. This is what is called dystichiasis. This is your dystichiasis. Okay, then second is this one. What is this? This is your thickening of the lid margin. This is called tylosis. Again, it will be due to chronic blepharitis. And what is this? Graying of eyelashes, poliosis. So all these terms you should know. Poliosis, where have we learned it? Poliosis. Viquet syndrome. Vogt-Koyanagi-Harada syndrome. You can get poliosis also in Waardenburg syndrome. Where we learnt about anterior lenticonus. So revise this. So these are the conditions. Okay. Arvind, can you please focus back here? All of you. This one is your last slide. So pep up and try to answer. I want you all to put the odd one out. I'm naming it A. This is the B. This is the C slide. D slide, E slide. Which is odd one out? And why? Okay, we are just at the last slide, guys. क्या हुआ? Okay, so all of you, I'm very sure in between you all must have got up a little bit. Look at me. Chalo, stop complaining. Fatafat, this is the last slide. Think what it is and think which one is the odd one out. Shivangi, batao. Tell me. Okay, so I'll explain you something here. What do you see here? A very important feature. These are Dalen Fuchs nodules. Where do you get it? Do you remember? We get it in sympathetic ophthalmitis. What is this? I can see edema in a disc-shaped manner. This is what? Disciform keratitis. What is this? I can see a flectin with congestion. This is flectanular keratoconjunctivitis. Can you find something common in these three conditions? And this is your candle wax drippings of sarcoidosis. Anyone? And this is your papillary hyperplasia, that is cobblestone appearance. Now which one is odd? A, B, C, D, E. Which one is odd? Okay. You all are sitting with me only? Okay. So this is the last. So sweet of you. Thank you so much. Okay, can you think of something A, B, C, D, E, which is the odd one out? Anything? Should I give you a few more seconds to answer this? Will you try? Why C is odd? You'll have to explain, Shivangi, why C, Madhukar. So why C is odd? ध्यान से देखो. Okay, I'll give you a hint. Think about hypersensitivity reactions. I'm giving you a hint. Hypersensitivity reactions. Tell. Okay, sympathetic ophthalmitis, it's a type 4 hypersensitivity. Disciform keratitis, type 4. Flectanular keratoconjunctivitis, type 4. Candle wax drippings. Candle wax, oh, so sorry, this is not candle. I'll just correct myself. Today I've made two mistakes. Then it won't apply. I'm absolutely very, very sorry for this. How come this is coming? It is not even, I was thinking it's not segmental, but na. वही होगा. I'm absolutely very sorry. This cannot be candle wax. ध्यान से देखो इसमें segmental नहीं है. And what it is just showing you the venous sheathing, and there are hemorrhages also. So actually it's a slide of Eales disease. I'm correcting myself. It's a slide of Eales disease. So now I will answer only. So again, Eales disease is a type 4 hypersensitivity, whereas when you talk about cobblestone appearance, it's a type 1 hypersensitivity reaction. So the odd one is E, that is this one. Okay, please correct that. Usko candle wax hata do. Again, some signs of getting fatigued now, isn't it? So anyway, so it's a Eales disease type 4. Please correct it, please. So sorry, Joy. Sorry. It is segmental nahi tha. I shouldn't have said that. So it was just a venous sheathing. So now you got it? Interesting tha? Could you find it a little interesting here? Okay. So now you all these topics are Eales disease, Dale and Fuchs, Disciform, Flectanular, Disciform you have learned in viral keratitis. We have talked about vernal keratoconjunctivitis. Flectanular very quickly is an endogenous allergy. It's a type 4 hypersensitivity reaction. Don't forget in flectanular, main endogenous allergy is Staph aureus and second would be tuberculosis. Revise this with me. Staph aureus and second option would be tuberculosis. Don't forget it can lead to fascicular ulcer, and if you talk about flectanular is also important. So quickly revising with you all, it's a fascicular. If this is a flectin, it will later lead to fascicular ulcer, and this fascicular later extends as ring ulcer. So then another question is on fascicular ulcer. ठीक है. Thank you so much for understanding and for giving my mistakes. Okay, before you all go, this is I have एक प्रथा बना रखी है that we will talk a little one or two thought for the days. So I just read this and I love this line, so I'm just sharing this with you. And the line, of course, I keep sharing with you about still I'm not discouraged. I have to keep working harder. Never give up, isn't it? So one more very beautiful line is victory always starts within. So the moment you believe I can win, I have to win, it will start within. You have to believe it very strongly, then act towards it even more strongly. Okay? Yes. So thank you so much. Oh, thank you so much for this compliment. Yes, never give up. Victory always starts first from within. Write it on your copy. Okay? Yes, I'm just immediately sending the PDF. Yes, so work harder and harder. Oh, so sweet. Thank you so much, Joy. One day I will meet your mother also. Right? Thank you. So, shall we leave? Now go take rest, eat something, relax, and then restart your revision. You all need a break. सबका पैनिक और मोटिवेशन लास्ट टाइम में आता है. It's absolutely human. Now it's how you really deal with yourself. Please just remember whatever time you are investing or whatever hard work you have done today. Suppose it is X, because now it's a countdown and the exam is very near. You have to run your own race. That means you have to be better than yesterday. It should be more than X. Better goes to 2X. If not 2X, then at least more than X. And then the next day should be more than the previous day. You have to just remember one thing: the more stricter you are to yourself, the more chances that you are going to win. The more self-disciplined you are and hard on yourself, that is what actual self-love is. Okay? Chalo, thank you so much. God bless you all. Stay blessed and keep smiling.